Should I start it?
No, Kripa,
Yeah.
give us a prompt and then I'll just start it off and hand it over to you.
So we are live.
Good evening. Welcome to AIOS Walk-in Patient Series. Today is second Saturday. So every second Saturday, we bring to you a series which starts with the title Walk-in. Means that if a patient comes to you with a particular problem, how do you identify that problem and how do you proceed further, triaging a patient and managing perhaps. So today we have taken up a very interesting topic that is periocular wrinkles and dark circles. This is a very common problem currently, and patients who are young may come to you with wrinkles and dark circle as their primary complaint. Even the elderly, once they are operated for cataract, they'll start looking at these wrinkles very critically, and then they might want a solution for it. Wrinkles, of course, are there, and dark circles are currently becoming a raging issue because of lifestyle changes, etc. So today we have put up a very elaborate webinar based on these issues. And the program director, as appropriately, is Dr. Kasturi Bhattacharya from Shankar Nethralaya, Guwahati, who specializes in oculoplasty and aesthetics. Chairpersons are Dr. Samar Kumar Basak, President of AIOS from Disha, Kolkata, and Dr. A.K. Grover, a celebrated oculoplasty surgeon from Vision Eye Center, New Delhi. Moderated by very strict moderator, Dr. Akshay Nair from Agrawal's Eye Hospital, Mumbai, and Mukesh Sharma from Center for Sight, Jaipur. We also have an expert panel, which is very vital for discussion. And we have 7 ladies here. Kamalpreet Likhari from Ratan Jyoti Nethralaya, Gwalior. Kasturi herself, she's a program director as well. Manju Meena, Chinese returned from Pink City Eye and Retina Center, Jaipur currently. Nidhi Pandey from Indira Gandhi, Lucknow. Roshmi Gupta from Trustwell Hospital, Bangalore, also Narayan Nethralaya, Bangalore. Savita Katoch from Disha Eye Hospital, Kolkata. Shilpa Taneja from the Eye and Face Clinic, New Delhi. Our very expert speakers, Dr. Aditi Mehta from Deval Eye Institute, Chandigarh. Dr. Kasturi Bhattacharya from Shankardeva Nethralaya, Guwahati. Dr. Milind Nayak, the first aesthetic surgeon from Hyderabad, LV Prasad Eye Institute. Prerna Tehliani from Mumbai Eye Plastic Center, Mumbai. Preeti Uday from DRR Eye Care and Oculoplasty Hospital, Chennai. And Shubhra Goyal, of course, from Clinica 5, Hyderabad. So we have a wonderful set of people here to take you through dark circles and wrinkles. Case presentation, Jayita Das from Disha Eye Hospital, Kolkata. Pallavi Singh from Vaikunth Eye Clinic, Ahmedabad, and Sahil Agarwal from RP Center, New Delhi. That's an elaborate program that Kasturi has put together herself, and she'll take you through the proceedings.
Thank you, Dr. Santosh, and thank you all in the Ophthalmological Society for having this very important topic, especially the one of the most common aging change, the wrinkles and the dry eyes. And I'm very much honored to have Dr. Grover sir here along with Dr. Samar Basagda as the chairperson of this webinar, and also a host of very well-renowned national and internationally renowned speakers who will be talking about the different aspects of the causes, the pathogenesis, the treatment of the wrinkles and the under eye circles. So, Grover sir, would you like to open the webinar, being the chairperson of today's session? You're muted, sir.
Thank you, Kasturi. Privileged to be a part of this. Thanks for making me a part of this wonderful seminar. Thank you, AIOS, Shamar, and Santosh. It's wonderful to see this subject. Shows how far we have come to aesthetics as a primary subject in one of our webinars of the AIOS. The journey has been stupendous from the scenario of oculoplastics when we started off with a very few people to the experts available almost in all tier 1, tier 2 cities now, with so many educational institutions where oculoplastics is done. Evolution from basic functional to aesthetics, and even there, people specialize in aesthetics alone, specializing in one special branch alone. It's been a big, big journey. Now, I can say with confidence that oculoplastics in India is now one of the leaders globally, not just for functional, but for aesthetics as well. Having seen all the courses that are done by our faculty at the AAO, at all the global fora, it's been a big, big journey from a time when no equipment were available, no instruments were available. to a time when we have the most advanced industry as well. A big journey and a big advance forwards. Pleasure to see the advancements and pleasure to have this subject, and looking forward to a wonderful session of your expertise of this group on periocular wrinkles and dark circles. Thank you.
Thank you much, Grover sir. And once again, thank you, Dr. Santosh, for having this wonderful topic. Like, it is basically the idea of Santosh. I'm only helping him have all the topics around. And so over to you, Dr. Akshay. Dr. Akshay and Dr. Mukesh will be moderating the session. So Akshay, would you like to call upon the first speaker? I think he must be busy. Then Shubhra, I think you're the first speaker, and Dr. Shubhra will, I think she'll cover a very important topic. Her topic is basically on the pathogenesis and the myths and the facts of the dark circles and the under eye wrinkles. Over to you, Shubhra.
Very good evening to one and all, and thank you, Dr. Kasturi, Dr. Honavar, Dr. Grover. I think, as been said, this is one of the most common conditions which we see in our clinics, and I always call it as bread and butter for oculoplasty surgeons or even ophthalmologists. So I have been given a task to talk about the myths and facts about dark circles, which I myself don't know what is a myth and what is a fact. So I'm just going to put some pointers here, and let's see what our expert panelists and the other experts on the forum have to talk about. Dark circles. I always question this to myself because are we really dealing with dark circles? What are we dealing with? Because for a common man, when they present to us, it's called dark circles, right? I always start my slide by a big gratitude to who all are responsible for what I am today. This is a very beautiful picture I just saw on Insta. I think I was just scrolling through. I'm sure some of you may have seen it. And if you just look at it from the close and distance, you can see how the patterns have been formed, and it's an elusive picture. So what fascinated me here is that most of the oculofacial problems, especially the periocular ones, are very elusive. We think that this is straight and forward, and there are, yeses and nos and pluses and minuses to deal with it. But actually, it's very elusive, very delusional, and we need to have a very detailed, holistic approach to what we are dealing with. Now, the dark circle is a misnomer according to the scientific literature, because, as I said, it's a layman's terminology. But what we are dealing here is periocular pigmentation, infraorbital pigmentation, and you can name it as and when. According to the latest survey, it affects around 10 to 15% of the world population, and I would say in India, majority of the population as such. So a dark circle patient or a periocular pigmentation patient would usually present to us in this format, and they would be talking about, they looking tired, groggy, sleepy. Some of them may just walk in for a cosmetic blemish. Some may just say, I have under eye hollows. So it's kind of a combination of everything which is present around the eyes. Now, myths are very easy to understand, and I think most of our consultation goes into answering about the myths. Unfortunately, the whole market of dark circles or periocular pigmentation is existing around the myths. So some of the myths I just highlighted, which I just thought, which came to my mind randomly when patients talk to us in the history, is lack of sleep, home remedies, long hours on systems, excessive crying, lasers, wonder cream, sunlight. So people relate to all kinds of things when it comes to periocular pigmentation. Lack of sleep does not cause pigmentation. We all know it. It just enhances it. Home remedies are a big fad. You can do it, but do they really help? No. Scientifically, we know no. Long hours on systems or excessive crying is yes, to some extent, they will increase the dark circles, because again, we're talking here about the vasodilatations and the water collection. There are no wonder creams, and sunlight exposure does not cause dark circles. It just causes pigmentation, which is the PIH. So I think we have to educate our patients regarding these myths. Now, when I was just scrolling through different types of dark circles, what the Google is talking about, because today everybody is a Google doctor. And these are the various pictures and formats I found out. There are types of dark circles, which is vasculature, sagging, edema, structural, mixed types and all. So everybody is kind of classifying dark circles or periocular pigmentation as per their own understanding about it. And this is another which we all have gone through, type 1, type 2, type 3, type 4, based on the pigmentation and then the causes which are associated with it. And these causes are well known in terms of, stressful lifestyle, aging. But what is really a dark circle? So the facts about the dark circles, what I have understood, and I'm sure the panel would agree to it, is that there are no standardized classifications till date which can be followed. There are no standardized treatment protocols. There are no magic pills, and there are no standardized diagnostic tools. Whatever we are talking about periocular pigmentation is just trial error combinations, and we are just doing tailor-made approach. So it is in fact a very complex entity. As I said, trial and error is what we do with mix and bag of the various treatment modalities. What we have to talk to our patients and clients is that it's not going to solve overnight. It's a long-term, treatment and a hand-holding with the patient, and we may not achieve 100%. And I think all the treatment modalities are being spoken after my talk by the esteemed speakers. Now, there are some good papers in the literature. One is by Tanuj Nakra on when he kind of reviewed the whole pathogenesis evolution of treatment and put it very beautifully about, what is the cause scientifically, understanding the anatomy, the structural changes. And we can go through this. And there is another very nice paper, which was published in 2015 by Goldman, where very nicely the type and the mechanism has been classified based on what we understand is basically the periocular pigmentation is about hollowing, which is shadow effect, pigmentation, vasculature, and something else happening in the body, which comes to the eyes or periocular skin. So I think this is a very easy and a simple manner with which we have understood the dark circles, apart from what the industry is talking about, and very easy for us to put it forward to our patients. So hollowing and shadowing, as we know, is age-related, related to the soothe, the skin, the bone absorptions and reabsorptions. Pigmentation can happen because of the changes in the skin itself, diseases, dermatitis, and other things happening. Vasculature, we know venous stasis or increased vasculature, thin and translucent skin again, which is aging. And then we have exogenous, like any kind of drugs-induced pigmentation, or it could be lifestyle-induced as well. So as I said, we need to understand the complete anatomy about the lower lid and the cheek, the lid-cheek junction, the soothe, the septum, the skin, the collagen changes, the pigment, the vasculature. We need to have our own tools to understand which is the main factor in each patient to cause it. So in a nutshell, I thought I would just put it here is that when we look at a patient of dark circle or periocular pigmentation, apart from the history, which is your hereditary and congenital or familial issues, we need to check from inside out, which is your bone framework, orbital walls, how they're doing, how are the vessels, how's the skin collagen and the fat tissue, and are we dealing with any shadow effect? And then we categorize them into the cause versus effect versus the etiology and the treatment modality. And I think that works the best in terms of treating it in a holistic manner. So here are some of the examples where this is a case of pure pigmentation. There is a bit of grade 1 hollowing, but this patient has classical grade 3 to grade 4 pigmentation, which has to be dealt with the combination of, fillers or cosmeceuticals. Under eye hollows causing the shadow effect, and you can deal with, injectables or otherwise with fat transfers, whatever. I think Milind is going to talk about it. Complex cases where you may have skin diseases, systemic disorders, skin laxity, hollowing effect, vascularity, all in together, and you need to deal with them in a very strategic and slow manner. Hill Valley skin laxity, we know what we have to do, and these patients have to be dealt one by one in a tailor-made approach. Then you have vascularity and pigmentation. These are one of the most difficult patients to treat because it's just grade 1 to grade 2 of periocular pigmentation, excessive vascularity, thin skin. Male patient, how do you tighten the collagen? How you take it forward? And I think Prerna is talking about the lasers and its use on the collagen building and pigmentation. Again, a complex case where you have periocular rolls, you have hollowness, you have vascularity, you have pigmentation, high expectation patient, and you do multifactorial or a tailored approach to deal with this patient. I want to bring forward this patient who presented to me. She's a nurse by profession, and look at her face, what has happened. So this patient was given some complex which had hydroquinone, and this is what has happened to her skin. Complete pigmentation or hypochondrosis of the skin because of hydroquinone. Very, very difficult to treat because this is after 6 months of hydroquinone constant use. We are dealing with it slowly. We have achieved this much of fading of pigmentation as of now, but it's a long journey forward where there are combination tools which we are going to work on and take it forward. And hopefully someday I'll be able to present where we landed up in this patient. So you can have complex periocular pigmentation in association with facial pigmentations, and a history is of paramount importance in these patients. So going back to the same paper by Goldman, I think it was very nicely enumerated. If you are following, what do you do? Pigmentation, what do you do? Vasculature, what do you do? I'm not a big fan of lasers in my patients, because most of the patients are not having skin prepped for the lasers to work. I'm sure speakers who are talking about lasers will have their own results here. But a combination of cosmeceuticals, injectables, and collagen building agents is something which really works well in my hands. Lasers is something which I deal and depend more on my dermatologist to see if the periocular pigmentation can be settled by that, especially when it is not a part of a melanocytosis or any other disorder which is happening in pure pigmentation or the disturbed melanocyte distribution in the deep dermis, which can be dealt very easily with cosmeceuticals. A very interesting paper, as I was telling you, that there are no standardized tools for us to see where, how can we classify or score the dark circles. So as usual, our Chinese friends have come out with AI, and they did it with the smartphones, and they looked at the skin types, the pores, the blackheads, the men and women, the age differences, and so on. And they kind of came to the conclusion on how the facial aging is changes as per the decade every 5 years based on their occupation and so on. I tried to formulate some program where I called it as bye-bye dark circles for my own clients, where I just kept it very simple, mild, moderate, severe, 1 to 3. And I had my own grading system. Based on what they present to me, I add the treatment modalities to it. So to just summarize, this is what dark circles or periocular pigmentation can look like. Patients can present with all kinds of theories, hypotheses. As a scientific leader, we need to understand what's happening in terms of the structural changes, skin changes, vascularity, and lifestyle. Of course, there are add-ons, like you can conceal it in some patients, you can go on the IV nutritions, you can add collagen builders, as I told you, and there are a lot of other things like carboxyl exchanges, PRPs, and everything which is in industry, which can be an add-on augmented tool. But what is more important is to understand why that particular pigmentation around the eye in that particular patient is actually happening. Thank you very much for your kind attention.
Thank you, ma'am. I think there was a very exhaustive overview of the pathogenesis, and also you've kept within your time of 10 minutes. So given that we have a separate allotted time of 30 minutes for discussion, we'll go through the presentations and then go on to the discussion. Can I invite Dr. Aditi Mehta to speak on the different cosmeceuticals for the management of the periocular wrinkles and dark circles?
Thank you, Dr. Akshay. Is my screen visible?
Yes.
Just go to slideshow. So I'm dealing with, I think, the dermatologist domain of this talk. So use of cosmeceuticals for management of periocular wrinkles and dark circles. Extremely grateful to Dr. Honavar and Dr. Kasturi ma'am for making me a part of this webinar. If we look at the data from the Southeast Asia beauty and cosmetics segment for the year 2020, the annual revenue is a whopping $25 billion, out of which the highest comes from the personal care segment. Now, this includes all the products which are available in a bottle on a jar, which are labeled as anti-aging, anti-wrinkle, skin rejuvenating products, which do not require any doctor's prescription. And people are able to purchase them and use them for looking better, looking younger. So, of course, like Dr. Shubhra highlighted, the approach for anti-aging is holistic, starting all the way from sun protection to collagen induction, energy-based devices, neuromuscular relaxants, and surgery. But today's talk focuses on these cosmeceuticals, which includes your sunscreens, your active ingredients, and your topical neuromuscular relaxants, which can be applied on the skin. All these products are available in a jar on a shelf in a supermarket, and you don't really need a doctor's prescription to get them. I will also be covering the chemical peeling, which is a pharmaceutical, which does require physician supervision for application. So how do they really work? Like, we have a building which withstands the time of the weather, the changes, the season, the sun, the rain, the thunder, and it weathers itself. So we have changes appearing on the outer facade of the building, even though structurally it remains stable. So how do you improve this? You whitewash it, you change the facade, you rejuvenate the outer surface, that's the skin for the face, and you make it appear fresher, younger, brighter, and aesthetically appealing. Before we proceed to what cosmeceutical to prescribe, we should cover how to evaluate the periocular area, in particular the points before prescribing different products for the patient to use at home. So although ma'am has covered this very, very well, but just a couple of things I would like to highlight. Don't miss out on lesions. Don't miss out on xanthelasmas, allergic dermatitis, sebaceous cysts, which do require more intervention rather than just giving a cream at home. One good way to document in the clinic also is to pick up the true pigmentation, is to take photographs without flash and then with flash. So over here, if we look at the first picture, she seems to have a lot of dark circles, shadow effect is also there. She has malar edema, she has a tear trough. But if you look at the picture with the flash, that has eliminated the shadows and the true pigmentation is highlighted very well. And this is what we'll be treating with the at-home or in-office cosmeceuticals. Another patient with the tear trough. So she came for her dark circles and all she needs is probably a filler because she has a good skin tone texture. She does have a little scar here, which can benefit with one of the cosmeceuticals. But for primarily the concern for the dark circles, she needs a filler treatment rather than a cosmeceutical. Another patient with wrinkles. So if you see here, addition of Botox and fillers will treat him better. And the picture with the flash, there is hardly any true pigmentation. So cosmeceuticals may not have much role over here. You do have to assess the kind of wrinkles around the eyes because when you're prescribing them any of the topical neuromuscular relaxants, these are what we'll be following up. And it's good to take a pre-procedure or pre-intervention picture so you can actually objectively show them the results later on. Periocular area also includes your forehead line, so this should also be accounted for. So coming to the treatment. So like I said, cosmeceuticals are skincare products which contain vitamins, minerals, and active ingredients for healing the skin and improving the appearance by focusing on the skin health, and they should deliver visible results, but they don't usually need a doctor's prescription. In the same realm also comes nutraceuticals, which are oral supplements in health foods. They are not prescription, but they're not the regular foods either, and they treat the gut health and the overall skin health. The third is the pharmaceutical, which are drugs used to prevent, diagnose, and treat diseases, and they require medical supervision for prescription and monitoring the use. So coming to the term cosmeceutical, it was introduced in 1984 by Albert Kligman. It's actually an industry term to reduce the amount of regulation required to bring the different products from the research lab to the factory to the shelf. So if you look at the US FDA definition, cosmetics are articles which are intended to be rubbed, poured, sprinkled, or sprayed onto the skin or otherwise introduced to the human body for just cleansing, beautifying, promoting attractiveness, or altering the appearance. Compared to this, a drug is a substance which is intended to affect the structure and function of the body. So cosmeceutical is a bridge between the two. A company who wants to launch a product which will have some kind of intended effect on the structure and function, for example, retinol, which is going to alter the collagen production, the level of thickness of the epidermis and the dermis, but they want to bring it fast to the market. They don't want to go through the regulatory peer review process for a drug which is required. They labeled it as a cosmetic. They'll label it as a cosmeceutical. They will follow some guidelines as to using ingredients which are generally recognized as safe. They do have a list of cosmetic ingredient review board, which guides the safety of these products, but does not comment on their efficacy. So when they're not commenting on their efficacy, they're bypassing the need for a peer review. Because if they comment on the efficacy and they find that it alters the body in a good way, it requires reclassification as a drug and thus more intensive regulation. Seeing this, we do have a tendency to dismiss all the cosmeceuticals as ineffective, but we need to understand that the term is just to limit the regulation, and they do have some potential benefits, and they can be easily incorporated into the at-home and in-office regimen while you're treating these patients in your aesthetic clinic. So coming to the product categories, the first and foremost is your photo protection, that's your SPF. This can be chemical or mineral. Mineral usually includes zinc oxide and titanium oxide, which are safe even in pregnancy and lactation. And the chemical ones are avobenzones, which need to be absorbed into the body and activated to provide sun protection. Sun protection also comes in the form of sunglasses for the periocular area. What you need to remember is that these SPF needs to be reapplied every 3 to 4 hours, and it is a proven efficacious method to delay aging, but does require strict compliance. Then you have the retinoids. So the ones highlighted in red are the over-the-counter ones, which are your cosmeceuticals. So if you look here, the least potent is retinol, which is easily available in most of your anti-wrinkle under-eye creams. Slightly more potent is retinaldehyde and then retinoic acid. Then you have the neuromuscular relaxants, which include your adrenaline, Leuficil, Vialox, and DABA, which act on reducing the acetylcholine-mediated muscle contraction. Of course, they're less potent than botulinum, but they reduce the appearance of fine lines and wrinkles, as highlighted by these two cases who have been using them regularly twice a day for 3 months, one of the formulations which contains DABA. Then you have the agents treating the hyperpigmentation, which inhibit the melanin synthesis by inhibiting the tyrosine kinase pathway. As ma'am highlighted in her last case, hydroquinone and azelaic acid are prescription. They are not cosmeceuticals, but the other ones like vitamin C, arbutin, licorice can be found in most of your skincare formulations, and they inhibit the tyrosine kinase and reduce the production of melanin. Then you have the keratolytics. Those are low-dose acids which can be used to loosen the epidermis to allow the penetration of other active ingredients and to improve the skin hydration and treat pigmentation. Antioxidants like vitamin C, E, and resveratrol, which minimize the collagen breakdown and protect the cells, the skin cells from reactive oxygen species. Growth factors, there's limited data available, but epidermal growth factors are useful in scar remodulation. And then last but not the least, they are the barrier function provided by moisturizers, which could be ceramides, urea, hyaluronic acid, which basically also serve as a medium to carry these ingredients and to deliver them to the skin. Coming to the in-office cosmeceutical pharmaceutical, that's a chemical peeling. So it is a minimally invasive skin resurfacing procedure. It's quite old. It starts from the age of French women and Cleopatra, where they used aged wine and sour milk to improve the skin texture and use it as a chemical exfoliating agent. It helps promote the collagen growth in epidermis and dermis, improves the fine lines and wrinkles, the pigmentation, as well as the scarring. It does have some skin remodeling effects depending on the depth of action. In the thin periocular skin, only the superficial peels are safe, which includes your fruit acids, your arginine, your low-dose trichloroacetic acid, lactic acid, citric, and phytic acid. Contact time is minimal, just a minute, and they do require neutralization and very careful application. They should not enter the eye, otherwise they can produce chemical injury on the ocular surface. This is a result of a chemical peeling over the past 4 months. So at baseline, she did have true pigmentation, and with regular, about 5 sittings have been done so far of periocular chemical peeling with a lactic resorcinol combination. There is significant improvement in the depth and the area of the pigmentation on the upper as well as lower lid, and the transition from the pigmented to the non-pigmented area has become smoother. Again, to minimize the effect of shadowing, these two pictures are taken with the flash on. And if we see here, the pigmented area, the color, the area has reduced after 4 sittings, and she is due to get more sittings in the future. Coming to the last slide, the word about the nutraceuticals, that includes your glutathione, marine collagen powders. So what we need to understand that these actually, they take them by the mouth. They're supposed to have some kind of efficacy. They say that when you're taking glutathione, your liver is benefited, your skin is benefited, your gut is benefited. But a person who is taking these regularly will also be concentrating on their diet, their exercise, their lifestyle regimen. And these can act as supplements to help improve and regulate their overall health rather than just targeting the skin per se. A word of acknowledgement for my dermatologist. Thank you for your patient listening.
Thank you, Aditi, for that very, very exhaustive overview. Just a couple of questions before we move on. While it, definitely all of these tend to affect the skin, it affects the gut, it also tends to affect the pocket. The cosmeceutical industry is for 2023 was $65 billion. And like you said, most of it is over the counter. How do you deal with patients, who are already, and we have so many Instagram dermatologists who keep reviewing products. How do you, they have a 7-step, 10-step routine. How do you deal with this in your clinic?
So as long as they're happy with their routine, you let them follow it, because this industry is not that regulated, because the term cosmeceutical is intended to bypass the regulation that a drug really requires. You do tend to believe, as a layman as well as a doctor, the more expensive the product, the better the result will be. And it's really difficult to convince the patients to shift to a cheaper alternative, which in clinical practice has shown good effect. But if a person is coming to me and asking me, what do you recommend? I will start with the basics, which after assessing the skin, if it's a dry skin or an oily or a combination skin, ask them about their lifestyle regimen, see their compliance, because these products are only going to work if they're going to be compliant to it. However, if they come with their own packet of all the ingredients that they have, and if the retinol has not caused any mebomytis, I'll never stop it. I'll ask them to continue whatever is suiting their skin and their pocket.
Right. Thank you. Dr. Kasturi, if I could just get your point of view, since you see such a spectrum of patients, just is there such a, I mean, clearly there is a need for regulation, because none of these cosmeceuticals come out with, randomized control trials or studies. So most of even the doctors who select them and prescribe them tend to do it on anecdotal basis. So do you think there is a need for us to, probably push for more studies that can actually tell us what works best in what concentration, and how do you select the product that works for you?
You're right, Akshay, but the thing is that first and foremost, we need to do a very good face analysis, because there are so many good face analysis. What we use, we try to analyze the skin, the underlying pigmentation, the underlying wrinkles. It is not that we see the patient and just jump on to you give them any of the cosmeceuticals. And what Aditi has already mentioned, cosmeceutical is a product. It is a device. It is not a medicine. Like in medicine, we have a dose. Supposing Ciplox, 500 milligram BD. So we have specific dose, but cosmeceuticals, they do not have. Even hyaluronic acid, it's not a medicine, it's just a device. So that always there's over or under, all these issues will come. But I really feel that if you take a good skincare, it really works. It really works, especially in situation like when you have too much of pores, niacinamide, it works so good. Retinol, it works very good for the fine lines. And also vitamin C, it is really good for, to brighten up the skin. So I really feel that the skin regimen is very important, and you religiously take it, it really works. And the most important thing is sunscreen. I have seen patients who never used to use sunscreen, and now every 2 hourly when I tell them that, and you should know what sunscreen you need as per where you stay. Like in my place, I always advise 50 SPF. So I have seen patient, I have seen the changes after using it every 2 hourly, how this whole skin has changed, including the change in the pigmentation and also the texture. So I feel that every aesthetic practice, not only we are doing only Botox, filler or this, we also have to address all the skin related issues.
Akshay, can I add here?
I'd
Yes,
like to
ma'am.
add one word here, that when it comes to regulation, it's, yes, as doctors, we feel this should be regulated, but it's the industry which doesn't want the regulation, because they want these products on the shelf quickly. So that is a point to consider, that yes, maybe as plastic surgeons, we should raise this point, that these products are leading to some kind of side effects, and some amount of regulation, even if it's not a randomized control trial, but some kind of regulation, or at least formulation for the Indian skin. Some studies like that should be done to really validate their safety.
Can I add one point here with your permission, Akshay?
Yes, ma'am, briefly.
Yeah, I think the bottom line here is to differentiate between skin care and skin health. Okay, that's the two basic terminologies which you need to make the patient understand. Skin care is over the shelf, skin health is under the belt of the doctors. Now, it is up to the physicians whether we are dealing with the health of the skin to bring it to the level where it is supposed to be, scientifically working on all levels. And that is where all the cosmeceuticals or nutraceuticals, which are just over the shelf, are never going to work. You need to have medicated, scientifically proven, FDA approved products to bring the skin health to that level. So I think care versus health is where you differentiate yourself as a skin analyst, physician, or a treatment person who's sitting there on the chair to give that result to your patient. It's very simple. So patient walks to my clinic, I never talk about good skin health, skin care. It's like healthy skin health. It's an organ which needs to be treated. Right? So I
That's
think we can change some terminologies and kind of put that in patient's head. And this industry of $1 billion or $1 trillion will continue to be there. You cannot stop it because that's a bread and butter of survival for everybody.
And I think the dermatology group loves to bring out consensus papers. I think this forum with these speakers is the perfect platform for us to initiate a periocular consensus paper on treating dark circles and fine lines and wrinkles. I think it's something that we can take forward. Earlier, it used to be dumped on me. Now I'm going to point to Aditi and say she needs to get everybody to do that.
So we need
And I
our
think
own range of products, I think, like all the dermatologists have.
And that could be step 2, formulated for
Yeah, so many
optimum eye health.
Yeah. Recently, I have given an exosome for one of my patients, and I could really see the change in the fine lines. So we also need to study, we also need to use more product and see our experience, like over long time, at least 1 year experience then, because everything is coming new. And I feel that exosomes are not bad. I was very skeptical using exosome, but when I have started it, I feel okay, it is definitely showing results. And I feel that it is not that without studies, these products are coming to the market. Some studies are definitely coming. I mean, some products are definitely coming to the market after studies. I think we have to go through each and every like Dabba. Dabba is there what Aditi has been mentioning. It is there in many of the what is this? Icerq and Vasuki. It is there in so many moisturizing cream also. So many other products. But what is the amount of Dabba? What is the concentration? It varies. So I think any product coming up by any pharmaceutical group, I think they are definitely doing some multicentric study to get it approved either by the CGI or through FDA, right?
yeah.
So, ma'am, they don't do a peer review. They do have their clinical data. You ask them for the data. They share their before, after, what scientific studies they have done. They do have published papers, some of them, the good companies, but they don't really go through the peer review process, because if they do that and there's an efficacy which is proven, then that is no longer a cosmetic or a cosmeceutical. It's a drug. And then the regulation required is much higher. So that's their way of circumventing. And yes, this needs to
Aditi,
be
I'm going to
addressed.
interrupt you and allow you to keep that meat for the discussion, panel discussion that we have.
Yeah.
I think Vico got it right all those years ago. Vico turmeric, nahi cosmetic. Anyways, moving on. I think from the realm that we share with dermatologists and aesthetic physicians, we'll come to something that is absolutely our own territory. And speaking on botulinum toxin for the management of periocular wrinkles is Dr. Preeti Uday.
Thank you, Akshay, and thank you for this wonderful evening. I don't know where it is from. Yeah, so it's lovely to spend this evening with all of you and this enriching discussions on cosmeceuticals. I now will talk on botulinum toxin for face rejuvenation. I have no financial disclosure. Now, when we look at the face, the periocular area strikes us first because this is the chief seat of beauty. But also the aging changes are seen earlier here because the skin is thin and there is no subcutaneous fat. And periocular rejuvenation is of prime importance in facial aesthetic in today's practice. Now, when we have a patient who walks in with wrinkles, which is the topic of today's webinar, we don't jump and straight away inject these wrinkles. We need to assess the face in totality because if you treat one area, the patient is usually dissatisfied. Imagine you having a 40-year-old forehead, but a 50-year-old lower face. So the entire face has to be treated as a whole. You also need to know the patient's profession, personality, as well as the aesthetic goals. Some patients may not be able to carry that supermodel look. You cannot have the same site of injections, which many of the students usually ask, what are the sites of injection? I think it all varies with each patient. And also the aesthetic goals of the patient and the profession. Sometimes you can have a Bharatanatyam dancer who needs the brow elevation for the dancing. You cannot knock that off. So you need to spend some time in the consultation. Preoperatively, photographs really help you or in static as well as in animation for you to give a complete plan of treatment for the patient. Now, Botox is indicated for dynamic wrinkles and fillers we usually use for static wrinkles. Now, these wrinkles also give you the facial impressions. and the emotional attributes. You know that this lion is angry. You know that this face is sad because the corrugators are bringing the eyebrows together. The depressor anguli oris is bringing the angle of the mouth down, and the mentalis is pulling the chin up. And when you weaken this or soften these muscles, you can change the emotional attribute of the patient. Now, similarly, this happy face, because she has a functioning orbicularis and zygomaticus major, and you must make sure that this kind of an expression is retained even after Botox, and you don't lose it by weakening the muscle too much. Now, whenever we refer to botulinum toxin, we like to use non-proprietary names. So for Botox, we use ONA botulinum toxin, for Dysport, abobotulinum toxin, and infobotulinum toxin for Xeomin. But one must remember that the toxin units are not interchangeable. So 50 units of Botox is not equivalent to 50 units of Myoblock. And also the effect starts after 5 to 7 days. So if the patient has a function next day, obviously this is not going to act. And usually they need it twice or thrice a year because the effect lasts for about 2 to 4 months. And muscle, now this, whenever you have a non-response to the injection, first think of incorrect technique or dosage or storage or incorrect dilution, because these are the commonest causes of non-response and not production of antibody. We don't see that very often in most of the patients. Now, informed consent is very essential. You can get the consent form from AO website. It is downloadable. And also you must document where exactly you're giving the dose and the site as well as the dosage, so that next time you can visit your chart and customize the plan accordingly. Also, you must assess the bruisability tendency of the patient. Not that you can't give the injection, but you can tell the patient they have higher tendency of bruising if they are on all these medications. And also no alcohol before and after the injection. Now, reconstitution, when you have a 100-unit vial, we usually reconstitute with 4 ml saline so that you get 2.5 units per 0.1 ml. So here you have a 50-unit vial. Now, you will see the drug as a vacuum-dried, purified extract from Clostridium botulinum. You can see it at the base of the bottle. The bottle has vacuum, so when you inject a 2 ml, here I'm injecting 2 ml because it's a 50 unit, the plunger gets pulled in because of the vacuum itself. And then you gently twirl it because the toxin is very friable. And then you aspirate it into a 1 cc syringe. So you get 2.5 units per 0.1 ml. Of course, when the patient has muscular dystrophies or anything that causes weakness of the muscle, Botox is to be avoided. If the patient has active acne, avoid it. Now, these are the whole lot of indications for which we use Botox in the clinical practice. Commonest being glabular frown lines. Now, the frown lines can be different in different patients. It is usually because of the action of procerus, corrugator supercilii, as well as depressor supercilii muscle. Now, this can be strong in one area and weaker in the other area. Like in this patient, she has a U pattern. So you give 1 injection in the procerus and 2 in the corrugator. So this is how you give. You ask the patient to frown so that you can see the muscle correctly. You hold the muscle. And then you inject deep because the muscle is deep, aspirate, and then inject 0.1 ml. Similarly, for corrugator head, it is a deep injection, but you keep the thumb at the orbital margin so that the diffusion into the orbit is less. And then the tail of the corrugator is more superficial, so that is a more superficial injection, again with the thumb at the orbital margin. Now, when you have a stronger corrugator, you can give an extra dose there, that is the V pattern of the frown line. Sometimes you can have converging pattern like this, where the procerus and the frontalis counteract each other, and then you need to inject only into the corrugator. If you have an omega pattern like this, the frontalis is also contributing, and therefore you can inject the frontalis also. And in an inverted omega pattern, you can inject the procerus along with the nasalis. Now, sometimes when one set of muscles are weak, the opposite set of muscles become hyperactive. So you can have increase in the bunny lines after you give this injection inside the procerus. Now, sometimes you can get a ptosis after this injection if you're not careful, if the depth of injection is not okay. And also if you do a post-procedure massage. So massage should be avoided after these injections. This diffusion can happen along the superior ophthalmic vein or transseptal. Now, coming to crow's feet, it is because of contraction of the orbicularis. Again, you can have various patterns like the full fan, upper lid, lower lid. Now, when you inject in the upper part, it is quite safe. When you weaken that part of the muscle, it causes a brow elevation, which is desirable. But when you come to the lower part, if you go below the Reed's line, which is the line joining the tragus to the ala, you have the insertion of the zygomaticus major. So in this area, you should not go very deep. Otherwise, the patient will have drooping of the angle of the mouth. So in this lower area, if you have to inject, it has to be very superficial and very, very low dose. And if you have some residual wrinkles, you can treat it with filler instead of giving higher dose of Botox. Now, if you knock off too much of the orbicularis, the patient's cheek will not go up while smiling, and they may have a non-Duchenne smile. Therefore, you have to be very, very meticulous in giving your injections in this area. Also, if the zygomaticus major is overacting, if the zygomaticus major is underacting or weakened by our injections, then the zygomaticus minor will overact and cause increase in the nasolabial folds. And also, if you have very much weakening of the orbicularis, the zygomaticus major starts acting more and gives this kind of a chipmunk appearance. So you can have various kind of combinations possible if these injections are not given accurately. Also, orbicularis muscle contraction is needed for lymphatic drainage, and when you weaken this muscle too much, you can have exaggeration of the lower lid bags. Now, coming to forehead lines, it is because of contraction of the frontalis muscle. And usually we don't go beyond the mid-pupillary line because you don't want the lateral part of the brow to droop. So we give in about 1 or 2 rows of injection on the contracting muscles, evenly placed, and you should keep the area about 1.5 centimeter above the superior orbital rim free of the injection so that you don't cause a brow droop. So this is how you do the markings, and then you inject 0.1 ml in each part. Now, sometimes the patients may have a few frontalis fibers lateral to the temporal crescent. Now, when you have these fibers, when you weaken the central part of the frontalis, the lateral fiber starts raising the lateral brow up, and that causes the Spock brow. Now, if that happens, then you need to give the anti-Spock point, that is another point which is lateral to the mid-pupillary line to counteract those fibers. Now, Botox is also used for eyebrow elevation. So what the points of injections are the same as glabellar lines to bring the medial part of the brow, to elevate the middle part of the brow. But you can also give injection on the lateral orbicularis to raise the lateral part of the brow. It is a very useful and very easy tool to cause a mild brow lift, especially if the brow is not very heavy. But if you have a very heavy brow, then of course you need a surgical correction. So this is a patient pre and post with a brow lift as well as a combination of fillers. Now, when you have bunny lines like this, you can inject into the nasalis muscle. And when you have platysmal bands, the patient is asked to clench the teeth, and you can give in 3 or 4 points along the band. Now, sometimes the patient has a hypertrophic masseter, and that causes the face to look like look squarish in the lower half. And those patients, you can give injections into the masseter muscle. So you draw a line from the tragus to the angle of the mouth, and then the anterior border of the masseter, and give about 4 or 5 points behind that. So they require usually a higher dose, about 50 units. Now, sometimes you can also give injections along the jawline to better define the jawline, that is the Nefertiti neck. So these are small injections right along the jawline to kind of snip that area. Now, if you have a gummy smile, then you need to negate the levator labii superioris allicinae. Now, that muscle is usually injected here, infero-medial to the nasolabial fold. Now, when you want to raise the tip of the nose, you need to inject right at the spine of the nose, that is the depressor nasi muscle. So these are small indications which can bring about large changes on the face. Now, when you have a depressed angle of the mouth, you need to inject in the depressor anguli oris muscle. Now, you have to be careful to be superficial with the tip of the needle away, facing laterally, so that you don't inject into the depressor labii inferioris and cause a lip ptosis instead. Now, sometimes some patients can have hypertrophied orbicularis roll like this. And this patient complained that the makeup can cake while putting makeup. She's in the media. So you can give small injections into this orbicularis muscle, taking care not to over-inject and cause a lid retraction. So these are very small doses given in the area of the hypertrophic orbicularis muscle. You can see the post-operatively, the muscle is more relaxed and the caking of the makeup is not seen. So pearls in today's talk is you must respect the surface marking, treat the face as a whole, and use the recommended doses and dilution. Do not chase the wrinkles. You can combine fillers sometimes in dangerous areas. And combination treatment with filler can provide myomodulation. And you should aim for natural results and not results like this, where you have an ironed and expressionless face. Thank you.
Thank you so much, Dr. Preeti. Just a small clarification for the benefit of our viewers. I noticed you use different needles on different parts of the face for the corrugators, the procerus, versus the ones on the forehead. What is your preference needle for the different sites around the eye?
So I generally use 30 gauge needle nowadays. Earlier I used to use 26, but usually 30 gauge. I don't use the insulin syringe much. So 30 is my preferred needle for Botox.
Very recently, I bought that 32 gauge, and you can call it a painless Botox now. Even without Prilox, it works so good. But you don't get it in India. So those are real good ones, 32 gauge.
But I think with the procerus and the corrugators, they must be getting blunt with that. Or do you have to change them mid-procedure for different parts or different needles?
I think when the skin is thick on the forehead, 26 works a little better than 30. But I know Dr. Joshi, Naresh Joshi uses 32 all the time.
And I think the retina surgeons use 34 for the TPA injections, intraretinal. So if we can borrow that, maybe we could even get the gauge down. All right. So with that, we'll move on to the use of biofillers and threads for the management of periocular wrinkles and dark circles by Dr. Kasturi Bhattacharjee.
You can see my slides, right?
Yes, ma'am.
Change this. So I'll be talking something different, and I feel that this is something. Oh, why it is not moving? So let me start by mentioning that one of the most common chronological aging change that we see in the periocular region is, why it is not moving, I don't know, is definitely the actinic elastosis. And because of this, we see so many changes, and which today we are discussing more about the wrinkles and the dark circles. And also this is associated with the volume deficit and the skin changes. So basically the actinic elastosis is caused by the UV radiation. And this UV radiation is associated by the formation of this reactive oxygen species and this increased production of the matrix metalloproteinases. These are, which are some of the studies that they have shown with induction of this transcription factor A1, and this causes the collapse of the collagen fibers. And along with it, the most important, the growth factor, this inhibition of the TGF-alpha, and these all leads to the actinic elastosis, and which can be variable, which can occur at the early age, or it can also occur in the late age. So today I'll be discussing one of the cutting edge treatment for the aging skin, especially the dark circles and the wrinkles. And this is basically the biofillers, which can be in the form of a PRP or a PRF. And both this PRP and PRF, they start the work by kickstarting whenever there is any microneedling or any injury. These gets activated. What they do, the platelets are being activated, and the platelets are the main source of the growth factors. And thus these are responsible for the collagen and other synthesis of the elastin. So this results in the firmer, plumper skin along with the reduction in the fine lines and the dark spots. So basically these biofillers are considered as a second generation autologous biomaterial having the platelets and the leukocytes, which are being enriched with the growth factors, and this helps in the regeneration of the mesenchymal stem cell and the cell differentiation. So today it is considered as one of the most important aspects where multiple researches are going on both in medical field and also in the therapeutical and pharmaceutical researches. So the stimulative effect of biofillers on the fibroblast includes multiple. The most important what today we all are discussing is definitely the skin texture gets improved, the color becomes more homogeneous, then increase in the elasticity, increase in the volume, definite reduction in the actinic elastosis that I have mentioned, and also there's definite decrease in the wrinkles. And it is really working because it is considered as a powerhouse of the growth factors. It is a powerhouse of the immune system messenger. How? Because the ideal platelet concentration is more than 2.5 times more over the baseline. And when we talk about both PRP and PRF, which now you both can have in a liquid and in a solid form, they the PRF is considered as a better option, especially for the deeper wrinkles and hollows, because PRF has a fibrin mesh, and this fibrin mesh, it acts as a reservoir and cause a very slow, sustained release of these bioactive growth factors. And the common growth factors that are present in the PRF is basically the platelet-derived growth factors, the fibroblasts, the transforming growth factor beta, which I have already mentioned, the VEGF, the epidermal growth factor, the insulin growth factor, the mesenchymal stem cell. So these, along with the fibroblasts and the leukocytes, what they form, they entraps and the mesenchymal stem cell, and thus this preserves its parenchymal function. And thus, this is how the platelet works, because the platelet itself is something which we call as a alpha granule. This alpha granule, which is present within the platelet, they helps in the formation of the other growth factors, and this ultimately leads to all the, skin changes, the better skin changes in the form of the collagen, the fibroblast synthesis, and the most important is the fibrin meshwork. This is responsible for the sustained release of the growth factors. So as I have already mentioned, both PRF and PRP today can be found in both in the liquid and the solid form, and the formulation is different. And this is how we do. We take the blood and once it is being centrifuged, so depending upon how much water is present, you can have it as PRF or it's sorry. It's very good, especially when you go for you can see the whole of the and you can also inject surface rejuvenation here. The method is much better than for the injection. But there are definite contraindications, especially for pregnancy, lactating women, patient with a history of altered skin healing, patient with a history of systemic disease like SLE, the thrombophilias, and those with the uncontrolled diabetes. So it's very important that we do a detailed examination of the periocular region. We need to know the anatomy, which my previous speakers have shown very well. You need to discuss with them very well, and also you need to review the photographs and explain the process, the recovery time, and also what are the potential complication. So when we do any of the, today we have been discussing about the cosmeceuticals, it's very important that you really need to assess the skin. You should have a face analyzer, and nowadays so many good face analyzers have come out regarding the type of the wrinkles that are present in the patient, the amount of tanning, the color of the patient, and we Indians basically, we follow you something in this group 4 to 5. So it's very essential that we know how to do a very good classification of the skin, and what I basically like is that the Glogos classification, which is based on the different types, which can be with no wrinkles, mild, moderate, severe wrinkles. And this is directly correlating with the amount of photoaging changes that we can see as the patient ages. And the face analyzer is really helpful, which really helps you to know what is the status. Like these are some of the patient where you can see she has a congenital lesion, for which after the treatment, this is how the pigmentation occurs. This is you can see the skin texture has improved, but with the same setting, when you see that after the second dose, you can see there's definitely an improvement in some amount of the skin texture, as you can see here, and she's still on doing it, and I think she will need every month she is going for this PRP treatment. This patient I really like to show, because she came to me with a functional indication. What she came, she had a low flow AV malformation, for which I have gone the bleomycin injection. And after the bleomycin injection, can you see how much recovery this AV malformation? And this is how the skin looks. And now I do a multiple face treatment and also the periocular region. This is the stamping technique which I'm doing with the derma pen. And then as you look into here, there's definitely change in the skin texture. And if you look to her previous photo, and now there's much better improvement. So many a times this liquid PRF or PRP also we inject into the tear trough region, and also for the fine lines, and the target areas usually I have already mentioned the periocular region, which can be injected both with a needle or with a cannula. And you do get some subtle changes before and after the injection, but it is not very evidently seen in a 2D picture, because when you really look into it, the patient themselves feel, yes, it looks better and they feel happy, but it needs at least minimum 3 to 6 settings. And this is how what we do when we go for a solid PRF. So the blood that you have taken, you will feel once you remove the liquid portion, you will feel there is a nice fibrin meshwork, which is between the RBC and the liquid PRF. And this is very important. You need to remove the RBC because the RBCs are really very toxic. It leads to loss of inflammatory reaction. So once you have this solid PRF, this solid PRF can be used for multiple indications, especially though I use for many of my functional indications, especially for my fractures, for my socket and the lid. But one of the major indications that I have been using is for the old scar. And for the scar revision, what I do, I use this because I really want the growth factors to be there. So the liquid portion also sometimes I inject, and with this dermapen, I try to push as much as growth factor along with it. And it is along also along with the liquid portion that has been injected. And you do get a change, but it's very important that you maintain a sterile environment. And this is usually how this solid fibrin it looks. You may or may not remove the plasma if you go for cosmetic indication, but for functional indication, I usually squeeze out some of the plasma before using it for my fracture patient. So this is after the squeezing the plasma, and this is with the plasma, but you can retain the liquid portion. And these are some of the changes. I feel the changes really looks good. This is how she came, and this is now after multiple sittings. I feel that it really helps to give a better improvement. This, I like to show this patient how I have used now the solid biofiller. So she has come with a scar like this, and like I was, she is very conscious. I think she had also treated elsewhere by 4, I think, dermatologists. Then when she has come to me, I told that surgery is the only option. So what I have done, I had made a small opening and I have removed that excess scarred skin. And after removing the excess scarred skin, I had taken the solid PRF. And this PRF, what I have done, this is a solid PRF, and this is the fat, the soup. So what I want to do, I want to have a base of this, and then once the fat is being sutured and made a base, so I have pulled the soup and made a base of the fat, and then over it I have placed a PRF. And then, this is you can see the fibrin. Can you see this fibrin? You can see the fibrin meshwork outer. So this whole of the PRF is being placed there. And once it is being placed, and then it is being sutured, and the skin has been sutured in layers. So PRF is also being sutured to the surrounding subcutaneous tissue. And you can see some of the changes. This is before, this is after a month, and this is after a few weeks. So this is how, if you see the RBC is very important. And I also use it for the socket reconstruction. Very recently, this also got this article published in the OPRS in this June 2024 series. So I feel that this PRF, this liquid biofillers, they really helps in your under eye rejuvenation, both for dark circles and for wrinkles. And being autogenous, there's no risk of the immunologic reaction. But as we had the first talk today for us was about the myths. What are the facts and what are the myths regarding all this use? The most common myth that many a patient they ask us whether it is painful or require lengthy recovery. I feel that these biofillers are very well tolerated and they have a very quick recovery. And also the second myth is that, is it for wrinkle? It is a stimulus for the collagen because I have already mentioned it has a growth factors. It promotes the overall skin health and elasticity. Third myth is that this PRF under the eye, does it give an instant result? Yes, no. The result usually is gradual. It takes weeks, at least 4 to 6 weeks to get the effective result. Is it not safe or does it have any adverse effect? I don't think so because it is your own blood and the chance of allergic reaction are less. And fifth, that is it only for the elderly age group? No, you can also use, like you can see in some of the functional indication I've used in a much younger individuals. So depending upon the indication, you can also address the issues based on the indication. A very brief about the thread, because we all know the threads are used both for the lifting. It is real, it works wonderful. I really love doing the thread because I feel that more than a filler gives a volume, but thread gives the actual lift. And because the threads are also enhances the collagen production. So anything which stimulates the fibroblasts will lead to collagen production. So along with the collagen and along with the tensile strength, the lift is much better with the thread. But it depends what type of thread you're using. So it can be non-absorbable. And very recently, I have attended a meeting abroad where I have seen the patients are using silicone thread and the results are much better than the facelift. surgical facelift, because nowadays patient has left this concept of going a deep plane facelift because of the complication and a long recovery time. So what people are doing, people are using this permanent silicone thread, and along with it, they're only doing a skin lift. So with the skin lift, they're only pulling the skin and cutting the excess of the skin, and rest they're doing a silicone thread. So I feel that thread really gives a good result, and this is the thread that I really like to use, this PLLA, and then now we have a combination of both PLLA and PCL. But the recovery time is, again, it looks the patient after the thread, the face swells up a bit. So at least after 1 to 2 months, recovery is much better, and it really lasts. It lasts for a year or almost 18 months or 2 years. Sometimes I use also this mono thread that you can see for the very, very fine wrinkles, especially these young people when they come to me. So this mono threads also use, it is not to take off the wrinkle, but only to enhance the collagen synthesis. Because I feel that we need to enhance the collagen, we need to stimulate the fibroblasts, and then only you will get a healthier skin. And along with it, if you do Botox, the results are much better and stays for a much longer duration. So these are some of the mono threads that I use for many of my patients, especially for my young patients, especially when they come for the very fine lines. And you can see some changes may not be very evident, but if you look, there's definitely some improvement. See, it has, I mean, it is not as deep as before, as you can see here and here. I can see there's some fading, so some amount of improvement. So to conclude, the biofillers, use of biofillers on the under eye is usually recommended for patient having the creepy skin, where you really need to improve the health of the skin. And the additional benefits, as I have already mentioned, that it really enhances the collagen production, anti-inflammatory, minimally invasive, and no downtime. So with this, I conclude. Thank you very much for the patient hearing.
Thank you so much, ma'am. In the interest of time, we'll move to the next speaker, Dr. Milind Naik, who will speak on the use of dermal fillers for addressing dark circles and under eye hollows.
Is it working? Am I stopped sharing or not?
Yeah, we can see Dr. Milind's screen.
Yeah, thank you, Akshay, and thanks to Dr. Honavar, Kasturi, and
Dr.
the
Milind,
AIOS for this.
Can you go to presenter view? We are seeing your rehearsal.
Oops, sorry. One second. Now, is that okay?
Yeah.
Okay, I thank Dr. Honavar, Kasturi, and the AIOS for this webinar, and the previous topics have been very educative. And I'll touch upon one aspect of this treatment in the periocular region, looking at dark circles and hollows with respect to how we can improve them with fillers. So what we are talking about basically is the mid-face, and fillers are used all across the face, but what we would restrict now is about the hills and valleys around the eye. And whether a patient is presenting to you in their young age, where this is definitely not an aging change, or when they present to you in the middle age or later, one of the common complaints in the periocular region is the dark circles, and partly at least it is contributed by the hollows, the hills, and the valleys around the eye. So if we look at the exact anatomy, I would recollect from one of our earlier publications. If you look at this image, which is stripped down to the bone, the black line is the orbital rim, and that's the anterior lacrimal crest. So if you compare that onto the photograph, your lacrimal sac would be somewhat superimposed in this region. And the one bulk which is right next to the lashes is your hill or the orbicularis roll, and your tear trough really starts below that. So tear trough starts at the lower edge of your orbicularis roll, which will have a slight depression because of the lower eyelid retractors, and it'll almost go up to the orbital rim. So your fat would be restricted in this area, and in the absence of the fat, what would be visible is going to be a hollow. So this is the same image, and we look at how the fat bags become more apparent when we look up, and they become less apparent when we look down. But even if you look at the region below the fat bag, you can see a tear trough. And how deep this tear trough is decides whether we are going to place fillers there or we are going to actually reduce the fat bag. So when you compare that to a horizontal or a cross section, you can see the fat bag is the actual fat which extends from the lower edge of the tarsus to the orbital rim. That's in line with the orbital rim. And your depression or the hollow is in line with the orbital rim. So if you were to palpate this person, you would almost always find the orbital rim in this groove, which is just below the fat. And as we age, this bone also partially resorbs so that the groove is going to become more and more deeper. So we will discuss primarily the patients who have only valleys or the ones who only have a trough. But before that, let's touch upon the simpler aspects, which is the patients who have just an elevation. And these are the right candidates just to do a blepharoplasty and take care of it. Sometimes the pseudo bag, which can be perceived as fat, is actually the prominent orbicularis roll. And you can lighten it a little bit by using botulinum toxin. When I see young patients who have a fat bag come with these tear troughs below it and also complaints of dark circles, the important thing is to suspect thyroid eye disease, look at their old photos, and here you can see that neither was the eyelid retraction present earlier, nor were the fat bags as well as the subbrow fat here. So coming back to our young patient who has only a valley, this would be a right candidate for us to inject a filler. So how does the filler principle work? Normally we have a straight line from the lashes to the cheek, but when we have a hollow, we are depositing these hyaluronic acid particles, which are cross-linked, and we place them closer to the bone in such a way that the hollow gets treated and you have a straight line from the lashes right up to the cheek. So that's how you eliminate the hollow to create a good filler effect. So here I'm treating this patient with 3-point injection technique. So rather than having the linear injection technique, I prefer to inject it in 2 or 3 areas and spread it out by pressure against the orbital rim. So I have already completed the mid-pupillary and the medial one. And here I'm just trying to feather it with the lateral most part of the filler injection. So you're basically depositing it within the tear trough so that you elevate it and eliminate the hollow. So these are a couple of examples of patients where the hollow has been treated. But again, in the context of dark circles, notice how the shadowing effect changes, although the light remains the same. And you now see less of pigmentation there, although we have done nothing to the skin. Here's another example where the slight tear trough was treated with a filler. You can see a little bit of Tyndall effect there. Another gross tear trough, which was again treated with fillers. So in each of these examples, you can notice that the shadowing effect treats the darkness around the eye, which is the shadow effect caused by the hollow itself, reducing after the filler injection. Here is the same from a side angle. And she actually had small amount of actual skin pigmentation here, which is persistent. So these are some of the examples of filler injections in young people. And sometimes you can even choose that to hide a very small fat bag rather than performing a blepharoplasty. You could just cover it up by doing the filler underneath. When you come to middle-aged patients, of course, filler is going to work not only to reduce the hollow, but it also takes care of the apparent hyperpigmentation in and around that because of the shadowing effect. These are 2 great examples. Here I've actually done only upper eyelid blep for this lady, and the lower eyelid was just treated with a filler. Sometimes you may have to do a blep in order to get rid of the fat bag, but instead of fillers, you can support that area with a fat transfer. And just like how you do a filler in the under eye region, you can also choose fat as an option, although my personal choice number 1 would always be a filler in a young person. And rare cases where you do a combination, you treat the bag first, and then you treat the hollow with a filler injection. Just a word of caution about the filler injections. So this is world literature on blindness that is caused by various particulate injectors. It could either be fat or a filler, and even PRP or triamcinolone has been known to cause these vascular events. So what happens here is because of the communication between the external and the internal carotid arteries, if the particle is accidentally injected into an external carotid branch and that goes retrograde to finally get lodged into the central retinal artery, you're going to have immediate irreversible blindness. And that sparks the debate between choosing a needle versus cannula. And several dermatology journals have come up with their own protocols of how to treat blindness with retrobulbar hyaluronidase injections, but nothing of this has been conclusively proven to be effective. So the world of filler injectors is divided between those who use needles and those who prefer cannulas. Thank you.
Thank you so much, Dr. Millen. It is interesting that dermatologists came with another consensus paper on how to treat blindness while we were sitting here blind. We'll speak, have the last speaker for the day before we move to the panel discussion. Dr. Prerna Tailiani from Mumbai will speak on the use of lasers for periocular dark circles and wrinkles.
Thank you so much, Akshay, and good evening to all my colleagues. So I just have a disclosure to make. I think it would be imperative that, I have this disclosure. So I'm going to speak about everything other than dark circles with respect to lasers. I hope you can see my slides.
Yes.
Yeah. So we all know this device, which is the luminous IPL, which is making the ophthalmology world go round. And I think when the company got done selling this device to dermatologists, they decided that, we can just change the handpiece and now target the ophthalmology circle and make some music about diseases that are not even treatable. What is a little disappointing is when we go and look at our own literature and we even look at textbooks written on lasers in ophthalmology, though we are the proprietors of lasers because we use it to treat all the structures within the eye. What doesn't it cover is periocular lasers. So I started looking into this by default, honestly. And I think we should all pay attention to what is going to be discussed here. So we are all masters of using radio frequency or energy-based devices. But imagine if you have laser in your armory and you could harness it effectively. So what miracles it could achieve. Looking at this middle-aged woman, now she comes into your clinic and this is a spot diagnosis. It's a no-brainer. This is a nevus of Ota and we are trained and tuned to looking at glaucoma or screening for malignant melanoma. But do you think this lady is driven to your OPD because she's concerned that she has glaucoma or melanoma? No. She has a cosmetic blemish and that's causing her psychological distress. So why do we always want to bat this back to the dermatologist or tell the patient just come back yearly for the screening? As Dr. Kasturi rightly says that we should conquer the face, so why not start with conquering the skin of the eyelid at least? So the two lasers that are my favorite, one more than the other, I'm just going to discuss about an ablative laser, which is the carbon dioxide laser that primarily targets intra and extracellular water, and a non-ablative or a pigment laser, which is the Q-switch NDAC that targets the melanin chromophores. All of this has to be obviously performed, keeping the ocular safety in purview. So carbon dioxide laser targets water, which means that you have to protect the cornea with an eye shield. The eyelid skin is thin, so you have to know the parameters to know exactly what depth you're working at. And a word of caution here is the heat dissipation. It's done under topical anesthesia is much more than the apparent area that is treated. So we have to be a little cautious. There are reports about corneal melts, cataracts, and all of that after carbon dioxide laser, which was aggressively done by cosmetologists. And then you look at pigmentation or pigment laser, which is the Q-switch NDAC, which is a dual wavelength laser. Predominantly, I'll be looking at the longer wavelength, which goes right up to the dermis. Here, you have to be very careful because the uvea is rich in chromophores, and the corneal lens by default will focus that extra accidental beam of laser directly on the macula and can cause blindness. So this is the carbon dioxide laser that I use. It is a standard machine, which is Deca X-side. And the predominant principle, how it works is, if you look at this diagram to the left, these red beams are the microablative zones. Without going too much into theory, what it does is it's a fractionated laser, which means that the entire area is not lasered between the probes. So the area next to the ablated zones is where is the photothermal zone. So this is where the bioactivation of the cells and the new collagen formation will occur. So looking at what indications right now I'm using them for is periocular wrinkles, scars, malar mounds, and definitely my favorite, which is an adjunct to surgical blepharoplasty. What is usually a downtime of the CO2 laser? So here is a patient who was treated for malar mount. This is 5 minutes after the laser. Usually you would tell them to ice it for 1 or 2 days and avoid harsh sun for the next 3 or 4 days. Though there are confounding factors in this case, which was a surgical patient, but looking at 6 months after surgery results, if you look at the depth of the malar mound, it looks marginally improved after mere 2 sessions of CO2. Though you can only have appreciable results after at least 3 to 4 sessions, and usually I time them 2 to 3 months apart. So this is another patient who came to me thinking that the under eye needs to be surgically treated, but I did not have a surgical answer for her under eyes. In fact, I thought I could symmetrize the upper eyelids better. So this is a 1 week result where you can see the suture is there just before suture removal, and this is how it looks, the grid pattern with the ablation and the area around the ablation. This is a 1.5 month result after 1 session of carbon dioxide laser. So usually I would definitely recommend it as an adjunct to surgical blepharoplasty. Sometimes you have these patients where even with the best surgical hands, you cannot do justice to the quality of crepey skin that they have. So very cautiously, if you know the parameters right, then you can use a carbon dioxide laser in adjunction with the surgery. This is a girl who had thermal burns in childhood when she was 2 years old. She came to us at about the age of 20, and not a very big difference, but you know the cases where you're anyway lost, you do not have an answer for the patient. If you look at her scars, the depth of the scar or the crater formation, there's definitely more filling. And the sheen and the lack of sheen over here talks about how the scar modulation has taken place. We'd also done a pigment laser for her. So this is another patient who had come to me with a brow tear that I had sutured, and after suture removal, I realized that he started developing a little gape, which is very common in the periocular area, especially around the thicker forehead skin. And he was a very demanding patient. So at 6 weeks, I did the first session of CO2 laser. And this is 3 months after, where I think the scar had improved, or maybe it would have had this sheen of gape, not so pink, but maybe a little bit of gape or a scar seen after 3 months if I wouldn't have done the laser. So it can also be used to knock off small bumps like epidermal nevus, and this is a 1 month result where you don't see a suture line or a scar. Coming to the next laser, which is the Q-switch NDAC. This is obviously done again with a corneal shield, which is a protective shield. I'm not going to go too much into the theory in the interest of time. So what I use it for is usually nevus of Ota. I use the 1064 wavelength in a focused and collimated fashion. It has separate probes for pixelated or collimated beams. This is before and after 4 sessions of focused Q-switch NDI. Again, now the new reports say that the spacing should be 2 or 3 months apart between 2 sessions. A word of caution here is that I definitely still don't treat the pretarsal skin. So I would retract the brow fat span and go over the bone. I would not direct the laser pointer directly over the cornea in spite of the corneal shield. Some of the indications where it works really great is nevus of Ota, melanocytic nevi, or badly done eyebrow tattoos and microbladed eyebrows or cosmetic eyeliners. Usual fluence that works with the Fitzpatrick 4 and onwards grade is 4 to 8. However, I think it's a wise thing to start at 2.4 or 2.5. Obviously, complications with the higher Fitzpatrick grade is dyschromia of the skin, and we have to be cautious about ocular damage for the patient and the operator. This is the same patient where the scar is lightened a little bit. In fact, she's between the sessions, and you can see confetti like hypopigmentation on the eyebrow skin. So, what is this next patient, and do you think she also got a very good result after laser, pigment laser? Any takers on this? So this is a cafe ole spot, and though there are reports claiming that pigment laser works well on cafe ole spots, what we have to understand is it's got a very high rate of recurrence and it's not safe, it's not medically indicated. This is because of the abnormal giant melanocytic granules that are there in the skin. So it almost always recurs. So just because you have lasers doesn't mean you point it at everything that looks like pigmentation around the eye. And while you can get very appreciable results with nevus of Ota, cafe ole spots are best left alone, or the patient can be counseled to use concealers. So just a small story, how I started doing these lasers is initially the yay phase was when I was only called in by the dermatology team to place the corneal shield. And then I realized that, it's not very easy. And every time I kept going back to reading the company manuals and understanding the physics and the bioreactions to it. But definitely, you have to know the physics. It's not a toy. Knowing the limitations of the device, eye protection is of utmost importance, and you have to be careful about ocular burns or reactivation of infections or hypopigmentation. Thank you.
So Akshay, we can keep at least 10 minutes discussion before we go to the case presentations.
Absolutely, ma'am. And I think, yeah, if the panel can turn on their cameras. So just a question to the panel in general. How many of you all work with dermatologists who can, help you with the lasers? Because, while the effects that, Prerna has shown, they're fantastic, especially the ones with the periocular pigmentation. I just want to get a sense of, is it easy to collaborate with a dermatologist or have a patient go and come back? Because there are certain things that we think we can treat better, or do we end up acquiring a laser machine? Because that's a huge investment from our side. And then, laser machines are like AIOS. Every month there's a new one coming out. So if I can start the discussion with Dr. Shubhra.
I think Shubhra just left.
Oh, okay.
So I'll pitch in. For me, personally, it's very easy. Probably, I think one of the advantages of living in a small town where a lot of my colleagues are also my friends or my batchmates. So for me, it is a no-brainer. I can just send them across and they send me surgical cases across. And also for me, it works out very well. But, just to digress a bit from this, while we are talking about the periocular pigmentation and fillers and all, we know that although it is not totally a lifestyle disease, a large part of it is contributed. We know that stress kind of, worsens dark circles, alcohol worsens it and all. So once we start a treatment, for the assessment, for the follow-up of our patients later, how do we follow up on their, their lifestyle things? How about if they've had a recent stressful event, or their lifestyle has kind of worsened and they haven't been sleeping at all, or so that definitely affects our the results. So there is absolutely no way of getting a patient to live a happy life while you are starting the treatment and to live a healthy life. So it's while we were talking about not having randomized controlled trials and most of it being anecdotal, I think that is part of the reason, because there are so many gray areas to this.
True, true. Again, the need for a consensus article. Aditi, I'm looking at you. Dr. Sabita
I
and
hear you.
Dr. Nidhi, just to get a sense of how frequently, in a busy practice, how frequently do you end up actually seeing patients who specifically come in for dark circles? And very often, I think there is a need for us to sensitize the general ophthalmologist that just don't send the patient away with refreshed tears or any lubricant. So do you find patients themselves referring themselves and coming in for specific treatment? I'll start with Dr. Sabita.
Yeah. So, am I audible?
Yes, ma'am.
So, I have seen that lately, in fact, in the recent months, there are people who do come to us specifically with dark circles. And maybe, let's say 2 years or ago, before, I would have not even given them a second minute of consultation. But now I do sit down and I talk to them and I try to understand what is going on. I mean, I try to give them more time. And we generally like to start with something like cosmeceuticals. But let's say earlier, even I wouldn't have given them too much of importance. Oh, dark circles, you know what it is, let it be types. But now I do give them a lot more of my time. That's the change that has happened with me as far as patients are concerned. And there are increasing number of people who do come with dark circles and they are worried about it, like as compared to the earlier years in our practice.
Dr. Nidhi, you have to add something to that?
The kind of patients I get are mostly drug reactions or VKC patients who are therapeutic, who need therapeutic this thing. It is a result of the therapy that they're taking. So firstly, eliminating the causative agent in most of the cases is the AGM, the anti-glaucoma medications. And I would sincerely, although there are no glaucoma people here, but I would sincerely use this platform to spread the word amongst glaucoma colleagues that please take a minute and review your drug regimen. It's one of your drugs that may be causing the patients, and just referring the patient to oculoplasty results in referring me back to them to reconsider their AGMs, because sometimes they are using 3 or 4 and it's like it's the glaucoma consultant's prerogative to find the culprit, maybe. So that's the kind of patients I get, and mostly it's and the dark circles are based for the lifestyle. I spend a minute or two in talking to them about their lifestyle, and with most of them are anemic kind of patients I get in a charitable hospital is anemic patients, and they who need to focus on their nutrition and diet. So that is the kind of patient category I deal with. It's quite different from corporates and private setting.
Right. Dr. Manju, your camera is acting a little funny. That you have a lot of periocular pigmentation yourself, but just to get, very often patients tend to have a lot of unrealistic expectations, and I often find that in my practice, they're trying to get them to, they have a certain standard in mind or an expectation in mind, and I think everybody in the panel can chip in. How do you deal with that in the clinic, and how do you set the counseling? What are the things that you'd want to say, what you'd want them to understand, and what not to say? I'd love to have Dr. Grover's view on that as well, but we'll start with you, Dr. Manju.
You see, if I know that the patient has very high expectations or unrealistic expectations, then I will prefer not to advise him any surgical procedure. In fact, I'll take an opinion of a dermatologist who can deal, if the patient is concerned about the dark circles, then I'll send the patient to have an opinion of a second doctor or a dermatologist who can treat them. But yeah, if there is some surgical intervention required, then obviously if we can assess the patient just by talking to him or her, or for giving time to the patient. If he's expecting too much, then obviously it's a red flag, and I'll avoid surgery in such cases, because they can be a troublesome patient in future. Because you cannot satisfy these patients, even if you sought opinion from different doctors. So I avoid operating such patients.
Yeah, and most of these the patients who've seen all of us usually end up finding their way to Dr. Grover. So, sir.
Let me start by saying that something works, because all our panelists, all our speakers, and they all have such bright skins and such fantastic faces, except maybe an exception like Akshay. So there is something that works. But more seriously, you have to tamper the expectations. There are so many of the dark circles that come as hereditary ones, where you have the mother with the same dark circle talking about her daughter. Now, there are those cases where all the speakers have shown such fabulous methods to improve things. There will be those cases, but to have those who are not going to show a change, or those who have lifestyle related things which Kamalpreet so eloquently spoke about, alcohol or diabetes or lack of sleep or depression or anxiety or things like that, those are not going to be helped. So you need to set the expectations right. Many of them have associated psychological issues which need to be taken care of. So unless we tamper the expectations appropriately, there's no point putting your hands into those cases. Only one more thing that I wanted to say was that we spoke about all those objective criteria for assessing wrinkles, about skin quality, and so on. So we do need control studies, as you pointed out, for many of the things that may not be graded as cosmeceuticals, at least in the things that Shubhra said are therapeutic. So where the physicians come in. So let's have many more trials with those objective criteria to have better defined treatments, better scientific treatments, or more evidence-based treatments.
Right. So I think just a couple of questions before we move on to the cases. Dr. Roshmi, if you're there, oftentimes we've seen in this entire panel, we've spoken about cosmeceuticals, topical neurotoxins, peels, lasers as well. So do you have like a step ladder pattern that you follow? Like the first thing that you treat is with A and then you step it up. And what is your go-to kind of product or procedure or something that you have that you'd recommend for patients who typically come in with specifically dark circles?
I think Roshni is not there.
Yeah, I think Roshmi is on mute. Then I'm going to direct that questions to two of y'all who see probably a bulk of these cases, Dr. Shubhra and Dr. Kasturi. Just quickly, so what is your first step, your second step, third step in that order in terms of lasers, cosmeceuticals, neurotoxins, or is it all of them together in a holistic fashion? I'll start with Dr. Shubhra first.
Yeah, thanks, Akshay. So I think there is no first, second, third for me. I think it doesn't work that way. As we discussed, you need to know what is the major cause for the condition which is presenting. So if it is hollowness, of course, your first step would be fillers. And fillers, and the one thing which I never take off the treatment plan is the skincare, for sure. And when I say skincare, I'm not talking about, so I'm using the same word, I'm sorry, the skin health. It's like unless you work on the skin, whether you are the entry point for the patient is the medicated cosmeceuticals. I'm using this word medicated cosmeceuticals. I think Aditi had mentioned about the cost factor, that there is a conception in the market that if it is expensive, it is good, and if it's cheap, it's not good. I kind of agree with that, because in Indian market, we don't have products which work. Okay, they just mask the effects of what you see, because if you have to really treat the skin from within, you need something which is scientifically proven, which has shown results over the years. And there are papers published and there are FDA approvals for that. So I think we all as physicians have to stick to that. Yes, you can have combination treatments here, because it's like main paradise biryani ke sath, need raita and achar also. So your raita achar will always be there, because you need to buy the patient in. So something which I always include is skincare based on the patient's understanding background. But if they're not committed to it and they're not agreeing to it, I tell them that without that, you cannot get the 100% result or near 100% result. Apart from that, Akshay, tailor-made approach based on lifestyles and all the treatment modalities which have been discussed by the experts. And we make a treatment calendar for the patient because you cannot really put everything in one go. And it is like a hand-holding over a period of time while treating these disorders. Dr. Kasturi.
Dr. Kasturi, quick response.
Yeah, I'll go very fast. For me, you need to see what is the type and what is the cause. If it is only pigmentation, then you have to start with the skincare in the form of kojic, arbutin, and also the azelaic. It really works good if someone is young and only with the pigmentation. Yes, if they have a crepey skin and if there's a volume loss, then you have to give the volume, and you can improve the skin texture with all the biofillers that I have mentioned, because I'm really doing it for the last almost 2-3 years. And when I keep on following, initially I was also skeptical, but I feel the results, nothing is above your own, I mean, the growth factors, about the collagen. So nowadays, so Aditi has shown about the glutathione, S6, right? I think in your slide. So we need to combine everything, especially in the elderly people. But in the young people, I think this cosmeceutical, especially the kojic, alpha-arbutin, and the azelaic works very good. In elderly, we might have to give them multiple things in the form of these cosmeticals, in the form of PRP, and also the glutathione S6, which is usually, works good for many patients. And ultimately, if there's really volume loss, then you have to give the volume. Then the best way of giving the volume is the fillers.
Sorry. Speaking of fillers, Dr. Milind, your preferred filler for a tear trough filler?
Yeah, I use the Juvederm, and sometimes I also leave it to the patient because I do get patients who have specifications about a filler. They might have had something done earlier, and they kind of believe that that's the filler that works. So if I have a choice, I use Juvederm.
Yeah, I think another thing which works quite well nowadays in my hands, and I'll just put it here, is the sandwich technique of fillers, where you do the HA fillers, whatever the choice of filler you have as personally for the tear trough deformity, and you kind of do the skin boosters along with that. And then you're combining with your skincare. Skin boosters can be PRPs, can be fillers. I mean, any kind of skin boosters which kind of work on the collagen. I think that's working pretty well periocularly.
Even Filament has come up with this exosome fillers. This also works very good. And Filament fillers are a little cheaper, but it really works good. But I feel the Juvederm Volbella, both of us are using. Even Restylane Classic is very good for under eye, and the Filament exosome. What Shubhra has mentioned, if we can combine both the filler and the exosome, it really gives a good texture to the skin.
May I ask a question? Okay,
Please.
there are a lot of plastic surgeons who have fat as their first choice. Now, why are we choosing the fillers? What are our reasons for our much greater preference for fillers rather than fat on the face?
So fat is number one. If you have a complication with hyaluronic acid, we have hyaluronic acid to dissolve it immediately. And secondly, if you really look, many a times the fat itself is a stem cell. Sometimes you get some of the fat, I mean, growing, like there may be bumps and lumps more in the fat than as compared with the hyaluronic. And secondly, the fat itself grows. In many a times you see, sometimes there are situations where after the plastic surgeon has given fat, so many times you had excised the fat, because and especially the abdominal fat is the highest source of the stem cell. And thirdly, if there's a complication, if the vascular complication may not be a blindness, but there's nothing to dissolve the fat. We have at least hyaluronidase to dissolve the fat. And it is easy. There's no second site manipulation. So these are the 4 major advantages. And other advantages, I think, it's a more minimalistic procedure than doing you harvesting the fat and making it into a nano fat or micro fat. You just directly get the filler, and it becomes much easier for the surgeon, I mean the injector also.
Also,
But-
sir, I think, sorry, ma'am, sorry. I thought you.
Please carry on.
Also, sir, the long-term studies of the nano fat versus the HA filler under the eyes, I think that has to be looked into. And what has been found is it doesn't really matter which we are doing HA now or nano fat. You're talking about nano fat because the fibrocollagenesis which is happening, the sausage deformities which are happening, the retractor recessions or the retractor pulls and fibrosis which is happening is almost equal in nano fat and HA. I think why all practitioners are shifting more towards HA is one, I think plastic surgeons inherently are not inclined towards fillers because they've always been the fat injectors. And we as occupational plastic surgeons are trying to take the path where reversibility and the quick results are in our hands. But I think if we do one side fat and one side filler, if some patient agrees, and we look at the long-term studies, would give a better answer to that. I don't think it has been done.
So nowadays PRP also we can make it a filler. We can make PRP, and many a times even we have just started, sir, very initial phase, just 1-2 patient we have started. Like PRP also you can make it solidify and you can actually give the volume. And the advantage it is working as a filler, but it will not stay for 3 months or so, the volume effect. But the skin texture is better than the hyaluronic acid. And that becomes the cheapest filler now. And most, I think many of the dermatologists are also doing. There's something very new coming, sir. And
I
it's
think
so cheap. With your own blood, you can do it.
I think Ramesh had a very beautiful presentation in one of these seminars where he did the periocular fat transfer. But the question is the long-term results. We are seeing that HA fillers are coming back with a lot of complication under the eyes, especially deformities, which can't be even excised. I mean, I've had patients where you open and nothing is there, but there is a sausage deformity which cannot be corrected. It cannot be reversed. So I don't know what is the long-term, let's say 5 years, 10 years follow-up of nano fat. And because it's a live tissue, there will be increase and decrease based on our BMR and, the change in fat tissue. I think those are the two basic things, which I feel personally is matter of the discussion and context and a personal choice at the end of it.
Great, thank you.
I think also for plastic surgeons, the blepharoplasty is just the dhania on top of the sabzi. They're doing the lipo, the tummy tuck, the breast, and then the patient says, "Acha, ye bhi kar do." So then they just, they've got so much fat, they might as well just put it for them. So
But I think the trends are changing now, Akshay. I think you had the first question of how many of us are practicing with the allied practitioners or these specialities. I think a lot of plastic surgeons leave aside the stereotypic. The new generation are understanding that blepharoplasty is a specialized way. Similarly, dermatologists, with no offense to anyone, see, a dermatologist is never going to refer you a patient for under eye fillers or Botox or anything. They would refer you a patient only when it's grade 4 fat prolapse. That's where you are called for, right? Similarly, for us, I feel as in combination for treatment for periocular pigmentation, we need to have a full knowledge of the skin health. And as much as we can treat it, unless it's a disease which is happening, which is not a territory of treatment, because then it becomes a medical legal issue and an ethical issue, where we should clearly refer the patient to dermatologist.
all right. Thank you. I think we've just enough time for the case presentations. Can I please invite Dr. Pallavi Singh to present her first case, and Dr. Manju can then take over the discussion for that.
Just 1 second. Is my screen visible?
Not your presentation.
Not the slides in the slideshow.
I'm just gonna put that up again. Is that visible now?
No. It's visible, but we see multiple things. Your whole screen we can see.
We can
Okay.
see your folder, not PowerPoint opened up.
Let me see. I'll just start that again. 1 second.
Do you think we could go to Dr. Sahil and come
Yeah,
back?
why don't we do that and then we can, yeah.
Right. Dr. Sahil, if you're ready, you can share your screen. We'll start with your presentation first and have Dr. Savita Katoch as your discussant.
So is my screen visible?
Yes.
Am I audible? Yeah. A very good evening to everyone. I am grateful to Dr. Kasturi and Dr. Santosh Nawaz sir for this wonderful opportunity. As physicians and ophthalmologists, we all come across cases with periorbital pigmentations, which most of the times could be of a cosmetic concern, but then they might leave behind some subtle clues, which could be of great systemic implication. So I shall present these 3 cases who all came with similar complaints of increased periorbital pigmentations for a due period of course of time. However, all 3 of them had a different clinical diagnosis, which was otherwise life-saving. So coming to this first patient of mine, a 55-year-old female comes with chief complaints of increased periorbital pigmentation over the last 6 months, which was increasing gradually and progressively. She had shown to a dermatologist outside who had asked her to start on some topical solutions, but that didn't work out very well. The hyperpigmentation didn't respond much to it. On presentation, she also gave me a short history of decrease in the weight over the last 3 months. On further examination, I found that she had increased hyperpigmentation also over the palmar and dorsal surface of the hand, as well as the feet, and there was increased knuckle pigmentation. So I was not very sure of the diagnosis. I just did a systemic workup, including a CBC, LFT, and KFT, and to my surprise, there was hyponatremia and hypokalemia sitting right there. And I immediately referred her to my physician colleague, who also told that besides this, she also had a recent onset of fatigue and generalized weakness. On repeat KFT, there was persistent hyponatremia and hyperkalemia, and on otherwise examination, systemic under endocrinology, they found that there was low serum cortisol levels and elevated ACTH and a negative abdominal CT, clinching a diagnosis of Addison's disease. The patient was later started on glucocorticoid replacement therapy, and besides systemic stabilization at 9 months, she had also good achievement of pigmentation, pigmentation, particularly of the periocular and knuckle area. My colleague also told me that one important clinical finding that I had missed out was that there is also extensive oral pigmentation in such patients, which is a clinching diagnosis towards Addison's disease. Case 2 of mine is a 60 years old female whom I had operated for both eye upper lid blepharoplasty and internal brupexy was done for her. She came to me after a year's time complaining of increased lower eyelid fat bags. But on examination of hers, I found that there was a generalized increase of facial swelling, and she was also looking hefty to me. She had gained some weight, and on asking her again, she also told that there was a differential pigmentation of the nail beds. I also see a physician immediately. She lost to follow up, and then she comes back to me after 6 months with further increase in facial puffiness. There was a lot of abdominal striations and growth of fine lacy lanugo hairs over the lower cheek. I immediately referred to an endocrinologist who, after doing a systemic workup, found out to be a case of Cushing's disease and stabilized her. She also told me that the referral was very important because on the presentation to him, the BP was shooting to 180 by 120. Coming to this third case, this was not primarily my case. This was a case referred from dermatology to me for ophthalmic examination. This young gentleman, 40 years old, with complaints of extensive periorbital pigmentation. On examination, there was periorbital pigmentation, which was velvety in appearance, along with temporal area as well as the nape of the neck. And there were multiple axillary tags, skin tags present. All of this pointing towards acanthosis nigricans. The patient was referred to endocrinologist for workup, and he was yet not diabetic totally and had developed insulin resistance, and thereby the treatment was done for him. So eyes as a window to the body and an attention to subtle clinical findings and a comprehensive approach, besides a multidisciplinary collaboration, facilitates accurate, timely diagnosis. May I request Dr. Savita ma'am to take on with the discussion part?
Can I go ahead?
Please, ma'am.
Yeah. So very illuminating, Dr. Sahil. I mean, this is the first time that I've seen such cases where you have to rule out such serious systemic diseases. And as clinicians, it remains our foremost duty to rule out any serious systemic problem. But we must also keep certain other systemic conditions in mind, which can have facial pigmentation like hemochromatosis, Wilson's disease. Even hypothyroidism could have some yellowish dyschromia, generalized yellowish dyschromia. So if we are in doubt, we can always ask for some basic tests. Another thing I would like to point out is we must always take a history of what drugs the patient is on. It's very, very important. Like antimalarials, like chloroquine, hydroxychloroquine, and chemotherapeutics like bleomycin, 5-fluorouracil, docetaxel. All these are supposed to have, can have pigmentations. Even minocycline, clofazimine, which is used in multi-drug resistant tuberculosis, can produce severe pigmentation of the face. And all these patients on these drugs, this is worsened by exposure to sun. So you have to tell them, please avoid sun exposure. I think it's very, very important. And also topical eye drops, as has been pointed out, like Latoprost, Bimetoprost, can produce diffuse facial pigmentation. Another thing to keep in mind is the chronic allergic conditions of the eyelids, which can lead to periorbital hyperpigmentation because of inflammation. And you could get a lot of crusting of the skin because of excessive tearing. And, then the tears become dried and all the salt gets deposited. And the chronic rubbing can even lead to LPS disinsertion and cause ptosis later on. Another thing I would like to point out is, especially in Indian circumstances, to keep in mind topical steroid abuse of the face. I mean, in India, in order to get a fairer skin, many people get over-the-counter topical steroids. They apply it for a long time, and they can come to you with chronic erythema, and the skin becomes very thin. And for these, we have to be very careful as to, ask about a history of topical steroid abuse. And of course, keep in mind what Sahil has pointed out so well. And it's illuminating for me too. I never would have thought of all these diseases, frankly. Thank you.
Right. Thank you. Dr. Pallavi, can you, while you set up your screen, if you have any other comments from the panelists?
Hi, Sahil, this is Prerna, your really nice case. So I think the first case that you showed, the middle-aged lady, which turned out to be Addison's, the top 4 things that were ringing in my mind were very often vitamin B12 deficiency can mimic the Addison's like picture. And I think not to also forget HIV-induced hyperpigmentation. And like Dr. Sabita mentioned, drug-induced reactions could also be a differential. But really interesting cases, and thank you for bringing them up.
Very recently, we have come across a doctor who was on clofazimine, and you can see the whole face has become totally pigmented. So it is very sad to see this drug induced. And recently, not one, I think 3 patients we have seen. And one, I think in the last in Kolkata meeting, we had also, I think she was also one of the participants. After taking clofazimine, the whole skin became highly pigmented.
I was referring to her only when I was talking about clofazimine.
Pallavi, you can start your case, please.
Can I start now? Is the screen visible now?
Yes.
Perfect. Thank you so much. Thank you so much, Kasturi ma'am, for the opportunity to present. And we've had an excellent discussion about the different kinds of problems we see with the periocular region. I'm going to present 2 cases, kind of building on Dr. Milin's talk when he was talking about the hills and valleys. And we're just going to talk about 2 patients that presented with the same problem, but were treated differently. And I'll have Dr. Manju discuss, what could have been done, what could not have been done. So this was a 23-year-old male who presented to me, and his complaint was that people would always say that he looks tired and has not had enough sleep. And he was moving to Poland for a job opportunity, so he wanted a permanent solution. Moving on to the second patient, she was a 37-year-old female, kind of a similar situation, complaints of eye bags, which were worse in the morning. But she was not really very keen on surgery because one of her aunts was an ophthalmologist, and she had said, you really should not get blepharoplasty done, which also kind of is an indication about how we need to sensitize our colleagues also about how safe these surgeries are. So just moving on to how these 2 patients were managed. This first patient, as you can see, he had like a mild fat prolapse, a small hill and a small valley, but he did not want fillers. I did give him the option of fillers, so we decided to go ahead with a reductive blepharoplasty, just fat debulking. And this was the result at 6 weeks, and he was fairly satisfied with the result. He was happy, so he's like, I don't look tired anymore. And as you can see in both the cases, that it was a good reduction. I would probably like to do a little more for his pigmentation, but he was happy. Moving on to the second patient, like I had said before, even though I had counseled her that she would be a good candidate for surgery, she said that she wanted to try something non-surgical first. So I dragged my feet a little bit, but then we did decide to go ahead with fillers because she had good skin quality. I explained to her what the implications are, how long it lasts and everything. And this was her result 2 days after surgery. So she was also flying out to the US. That was another reason why she did not want to get surgery done. And turns out she was a neighbor of mine, so we couldn't get pictures in the clinic, and that's why the lighting is different. But you can see even at 48 hours after filler, she was happy. She sends me pictures at 1 year post-op, and she's fairly happy with the results. So I think what we're going to be discussing basically is what are the factors that help with the decision making. And I think I'm going to let Dr. Manju take over now.
Yeah, thank you, Pallavi, for such a nice description of these two cases. So just, I also have a doubt apart from these points. I think the second case, I could see some asymmetry, orbital asymmetry between the two cases. The left eye, the fat looks more prominent.
Yeah.
Yeah. So did you rule out any thyroid or any refractive error such as unilateral high myopia or something? Because this globe looks prominent in this eye.
The refractive error was there was no refractive error because we checked that already. She had gotten her routine test done, so I not I mean, we just looked at the thyroid function test, and that was also normal. But what she also said that there was a little bit, so which is why I was not very keen on doing fillers, because it was slightly fluid related. She was a very vigilant patient. She would say that even with the menstrual cycle, she would see that sometimes the bags would get worse. So again, in these cases, because fillers would cause more fluid to come into that area, but somehow it just worked magically for her at 1 year. She's extremely happy. She's in the US and she's like posting a lot of pictures on Instagram. So I think she's it went well.
Yeah, it just, I mean, what I feel is that in my patients, generally, if there's excess of fat, I will prefer to do a transconj blepharoplasty with fat repositioning. That works very well because over a period of time, if you keep filling them over a year period or later on, they might develop some puffiness and that will stay forever. And sometimes this filler injection, they absorb water from the surrounding tissue and they become really, really prominent over a period of time. So if we think of long term, then I would still go for a blepharoplasty with fat repositioning. In this case, yes, the first case, he was doing really well. So I think that was the ideal option for him. Yes. Maybe the other panelists can give their opinion about this case.
Pallavi, nice cases. I think the first patient, did he ever complain about the pigmentation or he just came for bags to you?
So he just came for the bags. And that's why I was a little, I did not bring up the pigmentation because I was like, if it's only the bags concerning you, because for me, when I see the post-op result also, I feel like, there could have been more that could have been done. But I think one of the challenges, I think, which I would like to get the panel's opinion on, when you're in private practice, to be able to sort of, it's a tough line that you have to walk, what their concerns are. If you see any additional thing, do you point it out? Because then that will be another set of treatments. Like I don't do at present, I don't do peels or I don't do lasers in my own practice. So, and I'm, fairly young in my practice. So to get other people to do it, all of these challenges, I would love to get your opinion on how, how you can manage it as young in the practice when you're just starting out.
I think that would be the out of the scope of the discussion of the case today. We can have it offline. The second case, I think Manju has pointed out, I think the morning fullness around the eyes and the kind of fat prolapse she has and the kind of orbital structure. I mean, there is a prominence of there's some amount of exophthalmos. I think she has a subclinical hypothyroidism going on there. I think you need to rule out the thyroid antibodies. Now, in such kind of grade 3, grade 4 prolapse, yes, you have got very good result with fillers, but the long-term results you have to be very wary about with these patients. So coming to your point of what to choose for the quick fix, yes, it is good. But in the long term, this patient is going to come back to you with a lot of fibrosis around the fat and more Halen Valley. And that is going to be a little more tough blepharoplasty for you to do. That is the experience I have seen because filler is an easy way to go get away. In these cases. So I would, if I'm the treating physician, I would do fillers for the first pitch, which is obvious for everybody, or a fat repositioning even in the first case. And second is definitely a case of, depending on the skin laxity, whether transconjunctival or transcutaneous blepharoplasty.
And that's actually what I had counseled her for in the first place. I said, last the other thing, the last option that we have is fillers. And so fillers was not my first go-to. Like I said, I was really dragging my feet on this because she was clearly a very good case, for for a surgical management. But I think again, that's what happens because she was flying out to the US 2 days later and she really wanted to get something done. So we had an extensive discussion about the long-term things, that when she needs to get a blepharoplasty, she will need to get it dissolved. And I think the main thing that I emphasized was to not repeat the fillers again and again. And that's what I tell all my patients, that you really don't want to.
What I'm trying to bring on table here is not that fillers was not good and your result is not good. The point here is the long-term complications of fillers, which we are seeing more and more, and it has been internationally debated. And if you have grade 3, grade 4 fat prolapse, you need to put it in counseling sheet of your patients for your own safety. That's all. Yeah.
What
I think in the interest of time, we'll have to move to the third case. Dr. Jovita?
I'll just add one point because Pallavi's both the cases are doing really good. The patient is happy, the surgeon is happy, it's fine. If the patient comes with some complication later, then we can think of, but I have been giving fillers to some patient for the last 10 years also. It is not that everyone will have a complication. And how the fillers really conceals the fat. How it conceals the fat once you give the filler just below the orbitomalar ligament, this pushes the orbital septum and this is how the fat goes in. So if the patient is happy and I don't think everything is good unless and until they have a complication, because it's not all patient will have complication. Even with surgery, many people can have a complication. That is just my one, because I have been into filler for the last 10 years and I've seen really good results. More than 10 years, 2012 or 2014 I have started. But both the patients are doing good. Only one thing I can add, that when you do a blepharoplasty, always, if not all the 3 fat, do at least medial fat transpositioning. Because what happens, this will not only take care of that, whatever the fat and all, but later also the fluid retention will never happen if there's a fat transposition. There is no, even when we check, we ask the patient to look up and look down. Even after looking down, sometimes we see some amount of fluid. So if you see little amount of fluid, those patients must have 100% transpositioning. And later also, many times we need to augment all the initial cases where we had excised only the fat. Now, most of the patients nowadays, we are all augmenting with fillers. Because after 5 years, 10 years, you will have some amount of hollowness coming up. So every blepharoplasty, if not all the 3 fat, one medial fat pad needs to be transposed. Yeah.
I will keep that in mind, ma'am. Thank you.
Dr. Jovita?
Yes. Yeah. I'm sharing my screen. Am I visible? Is my screen visible?
No.
Not yet.
Okay.
But very interesting. Now, I never thought that this topic will be so interesting. So much to learn and so much to discuss.
Okay, is it visible now?
Yes.
Okay, good evening, everybody. Thank you, Dr. Kasturi, Madam, and Dr. Santosh Honavar, sir, for the invitation. I will be presenting here a case of an uniocular dark circle. So this is a 45-year-old lady referred to me from your UVA clinic. She has a chief complaint of left eye, darkening of the skin, and excessive watering from last 2 months. She has a history of tubercular vitritis diagnosed case, and she was on anti-tubercular regimen for last 4 months. She has a past history of tubercular choroiditis and vitritis in 2020. Now, currently, she is on prednisolone acetate 1%, timolol maleate 0.5% twice daily. Atropine was stopped 2 weeks ago. There is no such family history of hyperpigmentation of skin and periocular dark circle in her family. She is a housewife. There is no history of no sun exposure, and she is not allergic to any specific agent. On blood examination, there was no anemia. Her liver function and thyroid function test was normal. On ocular examination, both in the right eye, the vision was 6/6, and the left eye, her vision was 6/12. The cornea was clear. Mild conjunctival congestion was there around the lower fornix and also in the perilimbal area. In the anterior chamber, there was only few old capes. Fundus examination shows in the left eye, signs of healed vasculitis, sclerosed vessels, and choroiditis. So this is a definite case of tubercular vitritis. So now come to the periocular examination. Her skin type was Fitzpatrick type 4. There was dark brown hyperpigmentation of both the upper lid and the lower lid, and the pigmentation severity, it was more along the margin. There was thickened dark patch medially with a prominent skin folds. There was no crusting, no teatro deformity, no midfacial descent, and no prominent blood vessels. But however, she has some mild sunken periorbita and mild periorbital rhytids. And another point was she has a lower punctal ectropion with punctal stenosis. Probably this is the reason of her watering. So after this history and the clinical examination, we can come to the differential diagnosis. This could be a case of allergic contact dermatitis due to some topical medicine. It could be an irritant contact dermatitis, systemic drugs effect of antitubercular medicine, or it could be a nutritional deficiency. However, this patient has uniocular pigmentation only, so the systemic and the nutritional deficiency has been ruled out. So this patient has developed this hyperpigmentation after using this topical medication for some few weeks. So irritant contact dermatitis also can be ruled out, which usually occurs instance. So this is the case of an allergic contact dermatitis. There are many publications on this. So this is an epidemiological study done on periorbital hyperpigmentation here in Asian patient. Here we see that the vascular type is the most common, followed by constitutional, and next comes the post-inflammatory, that is the allergic type or any other drug reaction. Allergic contact dermatitis from a topical drugs is a frequent cause, and you see around 17% of the patient tested positive for contact dermatitis. It is a type 4 hypersensitivity reaction. In the first sensitization phase, the allergen taken up by the Langerhans cell and the macrophages of the skin, which presents them to nearby lymph node to the helper T cell. And in the effector phase, when there is re-exposure of the same allergen to the sensitized T cell, there is release of cytokines and other immune cell recruitment that lead to the inflammation. There are publications on various agents that which are the common allergen group that causes eyelid dermatitis, and we see this study from Denmark. Yes, this is the Danish study, and they have shown that the most common allergen group in this periocular allergic conjunctivitis is metal, followed by shellac, that is the cosmetic, that is the chemical agent which found in eye mascara, followed by preservatives of the eye drop, that is BAC, SOC, etc. Then topical antibiotic, fragrance, acrylates, and surfactant. Topical medicine causing allergic contact dermatitis. These are actually the type of the variety of the agents that were used in the topical medicine are varied in different part of the globe. Like in this study, they are showing that the antiglaucoma is the most common, whereas this is another study from UK. There shows that almost all medicine can cause the topical this allergic contact dermatitis. And in our patient, you can see this is the even the prednisolone acetate and timolol. Our patient was getting prednisolone and timolol. Probably this could be the offending agent in our case. The contact dermatitis and conjunctivitis due to delayed hypersensitivity, timolol has also been reported and has been reported. Patch testing is widely regarded as a gold standard test for allergic contact dermatitis, but it is not readily available in our setup, and it is not always very reliable. Only 19 to 21% patients shows positive patch test to ocular preparation. So the take-home message is allergic contact dermatitis should be considered as a DD of periocular hyperpigmentation, especially unilateral one. Prompt identification and discontinuation of the offending agents are crucial for resolution of symptoms. Patch testing may be a valuable diagnostic tool for identifying specific allergens in other areas of the part of the body. However, in ocular contact dermatitis, it is not always. There are high false negative results, and the ophthalmologist should have a vigilant eye to investigate this periocular hypertension in a step ladder pattern. Thank you. Now I request Dr. Nidhi to take over.
Yeah, very well summarized, Joyita, and an interesting case, and often we come across such cases in our OPD. So, in your experience and in the expert panel's opinion, what is the commonest eye drops implicated in such contact dermatitis patient?
Yeah, in my experience, I have seen phenylephrine, tropicacil. This tropicacil plus is one of the commonest, and then brimonidine and also nepafenac I have seen. And anti-glaucoma medication also there are like brimonidine. Brimonidine is very commonly causes allergic contact dermatitis.
Patient has tuberculosis, right?
Yes, ma'am. But he was not getting any like clofazimine was not given in her case.
Nidhi, you were telling something?
Plus, like she mentioned that it wasn't bilateral, it was just unilateral. So
yes,
that way systemic drugs could not be the culprit in this case. But I wanted to know, like, what to do in such cases. Like, Joyita, how did you go about managing this case?
Nidhi, just before that, Joyita, are you sure there was no use of prostaglandins to decrease the intraocular pressure for some reason when she had vitritis and so on? Although
no,
in
sir.
English,
I
that
have
would
checked
not
the
be the
patient
first choice.
folder. No, sir. I have checked the patient folder. Prostaglandin inhibitors has not been used ever. I've since
Because
2015. I have
usually
checked the patient.
dermatitis don't leave behind an appearance
sir.
like this. I haven't
Yes,
really
but she
seen
never
something
got.
like this. But you spoke about there being a decrease in volume, periocular.
Yes, sir.
Spoke
Yes, sir.
about pigmentation. So the commonest culprit would be a prostaglandin
Yes,
agent.
sir.
But in this case,
Latanoprost, but she never got, sir. She never.
Okay.
I just want to add one thing, sir, because she has mentioned the patient is having tuberculosis, and every tuberculosis patient, if you see the vitamin D level is it comes down. So vitamin D itself is a major cause of pigmentation, the crepey skin, all the skin crusting, and the volume loss. So always in tuberculosis patient, we usually check vitamin D.
Okay.
And vitamin D is a major cause of pigmentation, especially this
Yes,
region, vitamin D deficiency, and also the skin thinning out. That's why I asked regarding the.
Joyita, did you have any older pictures of this patient?
No, ma'am, I don't have. Actually, this patient referred for me from UVA clinic.
Yeah,
So
I think
I just
go
made the
through
patient.
her older pictures because the way the
Yes, ma'am.
pigmentation is lying there, it is definitely marginal and upper lid medial side.
Yes,
And we
ma'am.
need to go through her older pictures to understand where actually it is coming from. It is not looking like allergic dermatitis kind of a picture because the skin texture
Slide number 5. Slide number 5.
the
Just
skin
okay, ma'am.
texture
I'm just
the skin texture is pretty okay here. It's a very classical melanocyte thing. It's just margin and the medial lid,
And
it was
unilaterality,
thickened. The skin was little
unilaterality
thickened.
rules
there is
out
Yes,
so
sir.
many
there
systemic
is
things.
aponeurotic dehiscence which has happened. I
Yes,
think
yes.
topical steroids also, right?
Yes, 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 ma'am.
Yeah, so there's something more happening here. I think
I can see, I'm drawing pigmentation here. There's also some pigmentation here. There's pigmentation here. There's some pigmentation this part. Yes, definitely the more pigmentation over here, but I feel it's
Yes,
just more bilateral, just starting with one eye more and then going to the other eye. But see the pigmentation this part, this part. So I feel there is some systemic component to it. We need to also even just now Prerna mentioned the vitamin B12
Okay,
deficiency.
madam. Right, ma'am.
Yeah, one thing I would also like to say here, everyone has rightly pointed out, it is slightly bilateral, and the upper lid is very clearly involved. So if it is because of drops, it usually doesn't affect the upper lid. So I had a case recently which turned out to be lichen. So that also responded very nicely to tacrolimus and a mild steroid ointment. So like within 2 weeks, there was a miraculous clearing.
Joyita,
But Joyita,
Yes,
did
ma'am.
you try anti-allergics in this case? Did you
No,
try
that
taking her
mild
off?
hydrocortisone eye ointment only.
Did that help?
Eye ointment from yeah, yeah. After 2 weeks, it
means-
nearly it is resolved.
Yeah.
Complete resolution
I
of
have a
is it
Madam?
complete? Is it complete resolution of pigmentation with
Uh,
hydrocortisone?
Not complete, but it has faded out. But around 80% resolved, you can say. Patient is quite happy.
Because
Joyce, I just wanted to make
Yes,
one
yes.
comment.
hydrocortisone will cause the hypersensitivity of the skin in the long term.
Yes, madam.
To add the sunscreen with it, it would be interesting to see how this patient is doing actually. And these are very common cases. It's a very good case you're
Yes,
presenting.
yes.
We see a lot of them, maybe not unilateral, sometimes bilateral, very classical lid margin. I think this again comes to the same point of that no, not one pill fits all, and you need
Yes,
to,
ma'am. Right.
Shall I make one comment, please? So just
Yes.
in the history, Joyita, I think
Yes.
we should always take a history about hair dye or hair color, because I've seen similar cases
Yes,
who had the pigmentation around the forehead and around the eyelids, and there was a typical history of using hair dye very frequently. Obviously, I don't know the brand, but yeah, local dyes can cause such type of pigmentation and irritation around the skin of forehead and eyelids. In fact, whole face can be involved. So we should take out the history. Maybe the
Yes.
patient can.
Do you have the picture of treatment after hydrocortisone with you?
No, ma'am, I do not have that picture.
It'll be nice to see that. I mean,
Okay,
just
ma'am. Once the patient come back, I'll take.
yeah,
take.
it's interesting. It's a nice case. We need to understand the pattern of pigmentation, how it's
Yes,
healing.
yes, yes. Sure, madam.
And in cases of contact dermatitis, suppose we have taken the patient off the offending agent, started them on anti-allergics, and the pigmentation persists. How long should we wait? And do we have some treatment options for such pigmentations which are a result of contact dermatitis?
That's a case of PIH. PIH usually takes 6 to 8 months to resolve. So you have to take the agents off and keep treating the pigmentation based on how deep and what kind of layer it is affecting. So you have to counsel the patient for 6 to 8 months minimum.
I think very interesting session going on. In the interest of time, I'd like to thank each one of you. Especially, I would like to thank AIOS AIOS for having this webinar on wrinkles, and special thanks to Dr. Grover sir, who has been chairperson of today's webinar, and to all my respected speakers, my panelists, my dear moderators, and all the case presentations were very interesting. We wanted to give more time, but being a Saturday weekend, it is almost 9:30. So with this, we come to the conclusion of this webinar, and special thanks to Dr. Santosh, Santosh Honovar, who had taken all the interest that we should really have something, a 2 hours dedicated session on wrinkles. It is very, very innovative idea that he has come across, and I thank all of you for joining us today. So Dr. Grover, sir, would you like to give the concluding remarks of this webinar?
I would echo your sentiments. It has been a really novel choice of subject for a whole webinar. And we realized how much learning there was involved in this. And we have all certainly gained a lot of education today. Thank you for conducting it so well. And Akshay also. And of course, Santosh for organizing this program. Thank you.
Thank you, sir. So good night and happy weekend to all of you. Bye.
Thank you. Thank you all.
Thank you.
Thank you.
Good night.